Good morning, everyone, and welcome. This is the Connecticut Insurance Department's public informational hearing on the 2023 health insurance rate filings. This, as you may have heard, for those of us in the room, is being recorded. If you do not wish to be recorded, I would suggest that you leave now. If you are here, you will be recorded. We do have representatives from Cigna and Connecticut here today, and I am Andrew Mays. I'm the Insurance Commissioner of the state of Connecticut. Now, we're going to go through the whole process, but if at the end of the presentations and testimony, the public has any questions, they can use the Zoom meeting chat feature. So if you're online on Zoom, use the chat feature, or you can send an email to cid.ratefilings@ct.gov. Now, the weighted average request for the rate increases in the individual market is 20.4%. Connecticut Benefits requested a 24.1% increase. Connecticut Insurance Company requested a 25.2% increase. And the HMO, Connecticut Inc., requests an increase of 23.6%. The weighted average requested rate increase in the small group market is 14.8%. Connecticut Benefits has requested a 22.9% increase. Connecticut Insurance Company requested a 29.3% increase. And Connecticut Inc. is asking for a 24.5% increase. Also with us is Cigna. Cigna is asking for an increase of 19.6%. Connecticut Insurance Company entered the individual market on the exchange on January 1st of this year and now participates on and off the exchange. Cigna Health and Life began participating in the small group market on July 1st, 2021. And as a reminder, the small group market is defined as employers with 50 or fewer employees. Copies of the filings for all the carriers, that's Aetna, CVS, Anthem, Cigna, Connecticut, and United Healthcare Oxford and related documents have been posted on the Insurance Department's website for public review and comment since July 8th. As I mentioned, the proposed average individual rate increase request is 20.4% compared to 8.6% in 2022. And the range is from 8.6% to 25.2%. The proposed average small group rate request is a 14.8% increase, and that's compared to 12.9% in 2022, and ranges from 3.6% to 29.3%. These health plans that we are discussing today currently cover approximately 206,000 Connecticut residents. The Insurance Department is currently conducting actuarial reviews on each of these filings to determine if they are justified, and will make the ultimate decision to either approve, reject, or modify the requests in September. Now, given the way health insurance and premium increases touch the lives of consumers of these rate requests, I'm very interested in hearing from those in the community and their elected representatives whom you see here today about these filings. And I wish to provide an additional opportunity to the public to become informed about the specific rate proposals. And that is what today's informational hearing is all about. Insurance Department staff here assisting me are Paul Lombardo. Well, Paul Lombardo is not here. Unfortunately, Mr. Lombardo, who is the Assistant Deputy Commissioner for Life and Health, just tested positive for COVID, so he will be joining us. He is quarantining and will be joining us via Zoom. But Tricia Dave, who's our insurance actuary, and Jared Koski, our Deputy Commissioner and General Counsel, are here. We will begin with presentations from Cigna and Connecticut separately on their respective rate requests. The presentations are to be up to 5 minutes each, and we ask you that you explain your filings for both individual and small group on and off the exchange. The department will then ask questions of each company. At the conclusion of the presentations and the department's questions, we will open it up to the Attorney Generals. We have invited the Attorney General, the Office of the Healthcare Advocate, and the Office of Health Strategy for the next hour. Appointed and elected officials will follow, and they will each speak for up to 5 minutes. Then the public will speak in the order in which they have signed up for up to 3 minutes each. If any member of the public did not have an opportunity to sign up and does want to speak again, please send an email with your name to cid.ratefilings@ct.gov. Please address your comments to the given subject, be as concise as possible. If you've already submitted written comments, I'm going to ask that you be as concise as possible today as well. Please simply summarize them instead of restating them. When speaking, please identify yourself. Your remarks should be specific and relate to the pending Cigna and Connecticut health insurance rate increases that are before the insurance department. When you speak, please make sure that you speak clearly. Remember, we are on CTN and Facebook Live. And address your comments directly to me. I would also like to ask everyone to silence your cell phone or other electronic devices for the remainder of this meeting. And if you are not speaking, please mute your microphone. Now let me explain to the public, because I know we've got lots of interest. There's been lots of speculation. Let me tell you what the department asks of insurers to submit with their rate filings. Last year, we issued our annual bulletin, which was HC 8121, and my attorney is here, so he says I have to give the number, on health rate filing guidelines to all companies that deliver or issue individual and group health insurance policies in Connecticut. The public is encouraged to review that bulletin, and that's on our website at ct.gov/CID. And I do want to mention, I keep mentioning our website, pretty much everything connected to the health insurance rate increase request and the hearing are on our website. You're going to see the requests, you're going to see the questions that we as a department sent out. After this hearing is complete, you will be able to access the hearing itself. We believe in transparency. We believe in letting every member of the public with an interest in this know what we are doing and how we are doing it. Now, from the companies, what the department requires is consistent with the Affordable Care Act, the ACA requirements. And as a result, the Centers for Medicare and Medicaid Services Society, or the Center for Consumer Information and Insurance Oversight, has determined that Connecticut is an effective rate review state. The department has some of the best actuaries that you will find anywhere, and this includes my friend Tricia here, who's the chief health actuary, and of course Paul Lombardo, who is the assistant deputy commissioner for life and health, who before he became assistant deputy commissioner was a chief health actuary. Our actuarial analysis is guided by and consistent with the actuarial standards of practice. For those of you who don't know, there are standards that actuaries have to follow. It's all in writing. They have to agree with those in order to remain as actuaries. And our actuarial team analyzes each component of trend, including the unit cost, utilization, and severity. Just to explain what that means briefly, you take a look at utilization. For instance, during COVID, utilization was down because fewer people were going into the hospitals or going to their providers to request treatment. So that means the number of people that were requesting treatment was down. That's utilization being down. Now, after that, as we've seen a rebound in utilization, but we've also seen an increase in severity. And severity is a measure of the strength, the difficulty of treating the illness. If, for instance, you were not tested for cancer 2 years ago when it could have been caught early and you go in now, not only is it more difficult to treat you, but it is more expensive. So the issues with which people are presenting to their healthcare providers those issues are more complex, and that's what we refer to as severity. In addition to everything else, our actuaries back test the trend. They use actual historical experience, and they compare it to what was assumed at the time in the rate filing. So The rate filings are prospective, but what we do is we make sure that there was not too much given in a prior year. We want to make sure that as we look at it, the assumptions that were made were consistent with what happened. The actuarial team also analyzes any changes made to retention by comparing the current rate filing to historical filings. We test and evaluate every single assumption made regarding additional adjustments to the rates, including but not limited to experience adjustments, the impact of COVID, and any legislative changes at the federal or state level that will affect the cost of health insurance and of healthcare. Our actuaries evaluate the assumed risk adjustment and compare it to the latest published risk adjustment. The Life and Health Actuarial Division compares actual experience to that which is reported in the company's financial statements, and they evaluate the company's claim lag triangles in order to test their incurred claim assumptions. We want to make sure that what they say they had to pay for was what they actually have to pay for. So I want to make sure everyone understands that our actuaries spend a couple of months delving into every aspect of this. This is not send it to us and we will rubber stamp it. This is not a we will accept your assumptions. This is we will do what is best for consumers, and we spend our time making sure that what we base the approved rate increases on or what has actually happened, what is needed. So the rates, and this is our charge under law, are not excessive, they're not inadequate, and they're not discriminatory. Excessive rates serve no one's purpose. Inadequate rates, for the same reason, doesn't serve anybody's purpose. It doesn't matter if you've got a zero premium if the company is out of business and can't pay your policy. So we have to make sure that there is enough going in to pay for what is coming out. And of course, the rates cannot discriminate unfairly against any particular group. This is never one of my favorite times of year, simply because my personal view, I think everyone has a health care should be a right, not a privilege. And in this country, certainly for those of us who are employed and don't have the benefit of government programs, health insurance, whether individually purchased or provided by our employers, is how we get access to health care. I hate seeing rate increases. But I also know, having been here, that it's just like you go to the supermarket and you see the prices have shot up. It's not necessarily because the supermarkets are making more money. There's stuff in the supply chain that has happened. What we want to make sure here is that again, please be sure to shut your cell phones off. But it's okay. What we want to make sure of is that consumers have the care, they have access to the care they need. And at no point are they being overcharged for the health insurance that provides that care. We have some of the finest regulators in the world here at the Connecticut Insurance Department, and that is their charge, that is their duty, that is their goal. Nonetheless, rates keep climbing. Nonetheless, costs keep climbing, which means that whatever else we're doing, and by we, I mean pretty much all of us that you see here, whether it's at the insurance department, the Office of Health Strategies, the Office of Health Advocate, whatever we're doing, more needs to be done. We need to be able to look at the entire ecosystem and figure out where changes can be made, figure out what we can do to protect consumers. Those of you who paid attention to the last legislative session will know that the governor and the legislature agreed on cost benchmarking going forward from next year and other ways for us to try to manage the increase in healthcare costs. We want to make sure, we need to make sure that we understand all these drivers and that the public that everyone understands. And that is why I'd like to announce today that along with my colleague Ted Doolittle, and I think Ted is on the left, Ted is the head of the Office of Healthcare Advocate. He is the independent healthcare advocate of the people of Connecticut. And I will tell you, there are many times Ted and I disagree. We've done that loudly and publicly. But Ted and I both agree that we need to pull everyone in to see what's going on, to see if there are any loopholes, to see if there's anything we're missing, to see what else we can do. Again, because healthcare should be a right, not a privilege for those who can afford it. So we are going to hold an informational hearing. We're going to have more info on that in the coming weeks, but we are going to pull in not just the insurance companies that are under my purview, but we are going to ask pretty much everyone, whether it's big pharma, that the PBMs, the pharmaceutical benefit managers, the hospitals, the other providers. We're going to ask everyone to come in here and sit and share their information and answer questions from us so we can get a better grip. We can see what it is we need to do to better managing the increasing cost of healthcare. So please pay attention to our, it'll be on our website. I'm sure the Office of Health Advocate will have that information as well, and we will provide the information when that timing for the hearing is tied down. Now, to begin, I'd like to welcome from Cigna and in person, do let me know if I have this right and if I'm pronouncing everybody's name right, Wendy Sherry, who is a Vice President of U.S. Commercial Markets, and Sarah Souza, who is a Small Group Finance Actuarial Director. Do I have that right? Wonderful. And on the Zoom call, we should have Jeffrey Thompson, who is a Small Group Solutions Director of Cigna and Oscar, and Akiva Dworkin, who is a Small Group Actuarial Advisor for Cigna and Oscar. From Connecticut, we have Karen Morin, who's the Connecticut President, and Neil Kelsey, who is the Chief Actuary for Connecticut. With that, that is the close of my introduction. I'm sure you've heard more than enough from me, so I will turn it over to Tricia Dave, who is our Life and Health Actuary. Tricia?
Okay, is that working? Okay, thank you, Commissioner. Welcome, everyone. At this point, we'd like to turn it over to the carriers for the presentation. I guess we'll begin with Cigna, and then we'll follow soon after with Connecticut. Go ahead, Cigna.
Thank you. Good morning, Commissioner Mays and the Insurance Department staff. My name is Wendy Sherry, Vice President of our U.S. Commercial Markets. I currently spearhead our work to improve the medical cost ratio for Cigna's U.S. commercial markets.
If I may interrupt for just 1 second. I
Sure.
know I'd said that you were getting 5 minutes, but I think 5 to 10 minutes is fine, just so you know.
Thank you. Prior to this role, I was president of the Connecticut market and of Cigna Payer Solutions. I've been with Cigna and have lived in Connecticut for over 25 years. With me today, as mentioned just a moment ago, is Sarah Souza, who is the Small Group Actuarial Director for Cigna plus Oscar. And virtually with us today is Jeffrey Thompson, Small Group Solutions Director for Cigna plus Oscar, and Akiva Dworkin, who is the Small Group Actuarial Advisor for Cigna plus Oscar. Thank you for the opportunity to come before you today to present the reasoning and methodology associated with our 2023 rate filing for our Cigna plus Oscar off-exchange small group offering. At the onset, I'd like to make one major point that I hope resonates with all of you today. Even with the 2023 Cigna plus Oscar proposed rate increase, our premiums, which is the amount that small employers actually pay out of pocket, continue to be lower than the market average. Furthermore, for the silver metal tier plan, which is the most popular among small employers, we have the lowest cost plan in 6 out of 8 of the rating areas, which represents the majority of where small employers are located. So percentage increases are all relative to the base figure. And as such, while we may have among the higher proposed increases, we continue to have among the lowest actual out-of-pocket premium cost when all is said and done. As many of you know, Cigna is a global health services company proudly headquartered here in Connecticut. with over 70,000 employees worldwide, including more than 4,000 here in Connecticut. We are dedicated to improving the health, well-being, and peace of mind for those that we serve. Cigna delivers choice, predictability, affordability, and access to quality care through integrated capabilities and connected, personalized solutions that advance whole person health. All products and services are provided exclusively by or through operating subsidiaries of Cigna Corporation, including Cigna Health and Life Insurance Company, Connecticut General Life Insurance Company, Evernorth companies or their affiliates, and Express Scripts companies or their affiliates. Such products and services include an integrated suite of health services such as medical, dental, behavioral, pharmacy, vision, supplemental benefits, and other related products. Cigna maintains sales capabilities in over 30 countries and jurisdictions and has over 190 million customer relationships throughout the world. It was during my tenure as market president that we launched the Cigna plus Oscar offering in Connecticut. We recognized the need for more innovative, more affordable solutions for our small employers, and we partnered with a newer, innovative health company, Oscar, to bring together our collective best to offer a product that delivers superior value and a differentiated service experience. I'm proud to say that in a very short time, Cigna plus Oscar has become a popular and affordable choice with our small business employers. In fact, Connecticut has been our fastest growing small group market in the nation. We are on track to achieve 18% market share in only 2 short years since our launch. Small employers can and do have a strong voice in the market by choosing who they use for healthcare coverage. Cigna plus Oscar is proud to be their partner of choice and continue to offer lower than market average premiums across the state. Thank you.
Good morning. My name is Sarah Souza, and I am the Small Group Actuarial Director for Cigna plus Oscar. I'm a fellow of the Society of Actuaries and a member of the American Academy of Actuaries. I'll first address the Cigna plus Oscar product offering and then get into what our average percentage increase actually means for our premiums and compare that to our competitors in the marketplace to provide a more complete picture. In 2023, we will offer 20 plans across all metal levels, including 5 HSA plans, which represents an increase in plan choice from our 2022 plan portfolio. These plans will continue to offer extremely competitive rates for our price-sensitive small group buyers statewide. We offer a broad quality network of trusted physician and hospital partners that small group employers and their employees value. We have an innovative customer service model dedicated to Connecticut small group customers with a dedicated Cigna plus Oscar care team that includes a clinician and easy to use digital tools to guide customers to high performing Connecticut physicians and hospitals. Our plans include $0 copays for virtual care and access to a $3 copay drug list that helps reduce plan costs for as many as 88 common conditions like blood pressure, cholesterol, migraines, and diabetes. We offer convenient home delivery for prescription drugs enabled with the click of a button. We leverage the expertise and efficiency of Cigna's Express Scripts to provide customers with the right drug at the right time at an affordable cost. Furthermore, our plans reflect the importance of comprehensive whole person health, connecting the mind and the body. We include access to our full behavioral network and no charge access to our specialized behavioral health coaches for personalized help managing conditions like depression, eating disorders, bipolar, autism, and others. These are just a few examples of the features in our innovative plan design portfolio. For 2023, we have requested a 19.6% average increase, which varies plan by plan. This increase is driven by a number of factors. Approximately 3% of this rate increase was previously approved for Q3 2022 rates by the department and is related to trend restatement. Approximately 3% of the rate increase is related to Connecticut state assessments that were incorrectly not included in our 2022 rates. Healthcare trend drives the largest component of our requested increase, followed by our 2021 claims experience emerging higher than expected. The remaining factors of our rate change include benefit modifications to comply with updated actuarial value requirements and changes in operating expense expectations. With this increase, we project our ACA medical loss ratio to be 85% for 2023. Even with Cigna plus Oscar's proposed average increase, our premiums continue to be lower than the market average. And for silver plans, which are the most popular amongst small employers, we have the lowest plan in 6 out of the 8 rating areas, representing the vast majority of where small employers are located. Thank you, and we are happy to take your questions.
Okay, next, we're just going to do the next presentation before we do questions. I think we're going to do both the presentations first. Yes, so I guess we'll go ahead with the presentation for Connecticut.
Good morning. My name is Karen Moran. I'm the president of Connecticut. I'll begin my remarks with a brief overview of Connecticut and the markets we serve. Our company was founded in Connecticut in 1981 by a group of physicians seeking to offer a different health insurance option for employers and residents of our state. Our mission is to create healthier futures for our customers and the communities we serve. We offer plans to large and small group employers, individuals and their families, and retirees and others eligible for Medicare. Specifically related to the markets we're talking about today, after the passage of the Affordable Care Act, Connecticut committed to being part of the new safety net afforded to residents of our state. Connecticut renewed that commitment, even as many of the larger plans scaled back their investment and commitment to the community, while others left the market altogether. As a result of our deep commitment, today we cover approximately 80% of the individuals who access their healthcare coverage through Access Health Connecticut. So we understand very well that many individuals and their families can only obtain insurance through the individual market. Please allow me to now address directly the question of our 2023 rate increase. For an insurance program to be sustainable, rates must be adequate to provide for payment of claims and the administrative cost of running the program. For the past year, the total insurance premium that we have received is far less than the cost of care we have actually funded. The premiums previously approved by the insurance department were significantly below what was necessary for us to meet the needs of the members who depend on us. Over the past year, our losses for the individual market have been in excess of $65 million. The single most important driver in our proposed rate increase is to restore our rates to an adequate level. Continued inadequate rates will negatively impact our ability to meet the needs of our policyholders over the long term. This year, our proposed rates are higher than others in percentage terms, but in real dollars, our resulting 2023 rates would remain among the lowest in this market, as they have been since the inception of Access Health Connecticut in 2014. The rate increase we're requesting is necessary to keep pace with the continuing rise in healthcare costs. By way of further explanation, there are 2 factors that impact our costs annually. The first is the cost for each service we pay to hospitals, doctors, and pharmacies. And the second is how our members use their healthcare. Examples include emergency room visits, hospitalizations, doctor's office visits, prescription drugs, and radiology services. Beyond the need to restore our rates to an adequate baseline, a significant driver of the required premium is medical trend, which is the increased cost of reimbursing healthcare providers for the services they provide to our members. Utilization of medical and pharmacy services is exceeding pre-pandemic levels in 2022 and is expected to continue due in large measure to the needs of the people we serve. We expect the increased utilization we've seen continue as members seek care that was put off during the pandemic. And furthermore, and unfortunately, delays in preventive care and screenings during the pandemic have resulted in greater complexity and severity of conditions such as cancer. We also anticipate that our country will continue to experience variants of COVID-19, which will require treatment, testing, and vaccination costs for which there is no government funding to help offset. Additionally, we know from our contract discussions with providers of healthcare that doctors, hospitals, and pharmaceutical companies are seeking to charge more for their services in 2023. We also know that utilization of services will continue to grow. Together, these factors will increase the amount we spend in providing necessary medical care to our members. To be considered actuarially adequate, our rates must be sufficient to account for the higher cost and utilization of health services. Over the past 2 years, our approved rates have been inadequate to meet the rising costs. Given the role we play in the exchange and the significant number of members we serve, any inadequacy in the rates significantly is magnified in real dollar losses that are unsustainable. We agree with legislators and others that affordability continues to be an issue in Connecticut and across the country, and we stand ready to partner with all stakeholders to bend the healthcare cost curve, which begins with the prices charged for services. Our rates reflect these prices along with utilization. Our premium rates are built on what we are charged by hospitals, providers, and pharmacies, and the number and types of services our members receive. Addressing affordability requires participation and partnership from all parties, carriers, providers, consumers, and the state. We've embraced the state's point of view that increased access to and utilization of primary care is vitally important to maintaining good health and preventing catastrophic illness. We've launched an effort to encourage our members to seek a primary care physician. We are adding rewards to encourage preventive care, screenings, and regular tests and procedures. And we've just rolled out a new program to allow our members to receive comprehensive primary care virtually as part of an effort to continue meeting the evolving needs of how our members want to access the healthcare system. Connecticut has always been and will continue to be proactive in managing costs. We work with hospitals, doctors, and other medical providers to help control costs and improve health outcomes for our members. The rates we have filed reflect the following steps we have taken. We've engaged with medical providers throughout the states and 12 accountable care organizations and other value-based payment arrangements. We've expanded our oversight to ensure that our members are receiving care that's evidence-based. We've invested in disease and care management capabilities that target high-risk members for chronic conditions with a specific focus on social determinants of health and the diverse cultural needs of our community. We've also accelerated the delivery of wellness and disease prevention programs through our partner, WellSpark Health. In addition, we are working with others in the state to partner on developing solutions to reduce costs, expand access, and create better health for our community. These include supporting the Covered Connecticut program, which leverages Access Health to provide no premium, no cost share plan designs to certain low-income consumers who are not eligible for Medicaid. We also work actively with the Office of Health Strategy to establish the cost growth benchmarks. Such benchmarks have been effective in reducing costs and reducing premium in other states. And finally, we're continuing to work with OHS on driving improvements to primary care utilization. From a policy perspective, we strongly support the continuation of the advanced premium tax credits, which are provided through the American Rescue Plan Act of 2021. The enhanced tax credits directly address the issue of affordability for many individuals seeking insurance coverage and are crucial to the sustainability of the ACA. Throughout its 40-year history, our plan has worked to be a strong partner to the beneficiaries we serve, to the state, to consumer and business communities, and in partnership with our clinical partners. That has never been more evident than the past 2+ years when the state faced an unprecedented pandemic. I would like to briefly share with you some of the critical actions that Connecticut took to remove barriers to healthcare during that time. We swiftly implemented a number of efforts to ease access to healthcare and remove many out-of-pocket costs to our plan beneficiaries. We're also very proud of other initiatives that we deployed during that time to provide our members with support that they needed that went beyond traditional health insurance. For example, Connecticut created a Peace of Mind initiative to provide members with help during the pandemic. Connecticut nurse managers and customer service representatives proactively called tens of thousands of our members who may be more vulnerable to the coronavirus and provided critical information to help keep them safe. We assisted with a wide variety of needs, such as arranging for easier access to prescription drugs, and provided general support to help deal with the stress and anxiety caused by the pandemic. We also worked with the Connecticut Department of Health to host COVID-19 vaccine clinics in our retail centers throughout the state. And our efforts have not stopped. In fact, on September 10th, Connecticut is hosting a free community wellness event in Hartford with health screenings and more to encourage families to get care. I share these brief highlights of our response to an unprecedented time in our state to reflect how committed Connecticut has always been and will continue to be to the people who use our services. In conclusion, our requested rate increases are quite simply a reflection of underlying costs that must be addressed for Connecticut to maintain a viable plan offering for our individual and small group clients. It is also important to note that is a plan directly focused on the community. Should we achieve any surplus, those dollars are continually reinvested in the community through our charitable giving, our ongoing efforts to improve our customers' and consumers' experience with us, and investment in reducing disparities in healthcare, rather than being returned to individual shareholders, as is the case in publicly traded companies. Furthermore, any surplus that exceeds regulatory limits as set forth by the ACA are returned directly to those who paid for the premium. We are committed to working with legislators, state officials, providers, and others to address affordability and the consequences of disparities in healthcare. Together, we can improve upon the strong system we have in this state and create a system that's accessible and affordable to all. These improvements to the system will take time and cooperation, and we will do all we can to influence real change. However, until those underlying costs can be addressed more holistically, in the near term, we must achieve premium levels that are adequate to continue providing services to the Connecticut residents enrolled in our plans. We desire to continue being the partner that you depend on, and we consider our responsibility during this process to be transparent about the inadequacy of premium over the past 2 years and our goal of resetting the baseline going forward. In short, we have not requested any more than we absolutely need in order to remain part of the exchange. We appreciate the thoughtful review and consideration that we're confident will be given by the insurance department as they review our fact and data-driven rate requests. We appreciate this opportunity to explain our filing and look forward to your questions. Thank you.
Is that it? Okay, thank you for your presentations. The department will now take an opportunity to ask, follow up with some questions. I guess we'll start with Cigna. Please explain any adjustments to the experience year, which is 2021, for COVID to better reflect the projected 2023 experience, including the cost for vaccines, testing, and treatment.
In our experience rate, we have adjusted for COVID-19 because our trend rates include adjustments to normalize for the historical and projected impact of COVID-19. This means that it includes the higher jump off point in 2021 and the expected reduction that we see going forward. That is reflected by the experience that we shared in our objection response related to COVID-19, that we had higher COVID-19 related costs in 2021, and we project those to come down into 2022 as our experience is showing, and we expect that it will further come down into 2023. The trend adjustments that we have incorporated result in the equivalent of 0.9% of claims expectation for COVID-19 in 2023.
Thank you. Please detail any morbidity adjustments made to the 2021 experience to project 2023 rates and state if each would result in an increase or decrease in rates.
We made two types of adjustments for morbidity to our experience rates. The first type of adjustment we made was related to the overall market and how we expect the morbidity of the market to change from 2021 to 2023. This is an increase to our experience rate and reflects the typical contraction that we have seen in the Connecticut small group space over the past few years. More than offsetting that is an adjustment that we made to our own experience, and that is related to the fact that we anticipate that the risk that we attracted in 2021 is higher than the market average, and our rates that we have put forth for 2023 anticipate that we will have a typical market average risk profile as our plans continue to grow and attract small businesses and their employees onto our plans. That was a net reduction to our experience rate, and in total, morbidity accounted for a 2% reduction to our experience rate.
Thank you. There were a couple, acts that have been passed, 2021 and 22. Can you just give us a quick summary, the percentage of premium impact on the pricing for the 2023 rates for some of the main pieces, one being the enhanced like diabetic coverage services passed in 2021. And in addition, more recently, there was some enhanced diagnostic and screening services covered for cancer. And then lastly, there was a new mental health mandate to cover child visits on mental health.
Sure. So these mandates may have an adverse impact on our claim costs. However, Cigna has not made adjustments for these mandates in our 2023 pricing. Based on our initial review, we believe that Public Act 2290 will likely have a cost impact, but at this time have not yet incorporated it into our 2023 premium rates and will continue to monitor the impact. Related to Public Act 2114, those costs are already incorporated into our rate filings, and we do not expect further impact.
Okay. Also, the current Connecticut Small Employer Health Reinsurance Pool has been in place since 2018. All carriers pay into the pool, and large claims are partially reimbursed to smooth out claim experience. As a reinsurance mechanism, this should be theoretically revenue neutral over time. Can you explain why you're pricing the 2023 rates with a cost associated with the pool?
Sure. In our rate development, the program that you're referring to is the reinsurance program, affectionately known as CSIRP. And that was, we developed our assumption for 2023 based on a 50% expected recovery rate at the 2020 assessment level. We used this approach for two reasons. One, we were a net payer in 2021, and we have no reason to expect a different outcome in 2023. And two, we reviewed publicly available rate filings for carriers that are more established and have more experience in the CSIRP program. And that was our source for the 50% recovery rate. We expect to continue to monitor this program and the results.
Did you reflect an administrative fee along with that cost separately, or is that part of your assumption with the 50% expected recovery?
It is part of the assumption.
Okay. Thank you. And as you know, trend is a significant component of the rate changes proposed for the 2023 rates. Trend is the factor that accounts for the rising healthcare costs, including the cost of prescription drugs and increased demand for medical services. I had sort of three pieces to the next question. First, can you summarize the trend you're proposing for the 2023 rates and how that compares to your currently approved trend? Secondly, what are the largest drivers of your trend and the main reasons for the changes since last year? And then lastly, can you just walk us through your processes in determining your future trend, including your reliance on historical trend experience and the addition of any factors not reflected in past experience?
Can you repeat the second component?
Yeah, just what's the largest drivers of your trend and the main reasons for the changes since last year?
Sure. So our experience trend from 2021 to 2023 is a total of 7.2% trend. As many in the room know, our premiums and these trends reflect the underlying cost of care, and there are multiple components to why these trends increase year over year. You have three components that I'd like to mention. One is the cost of the care. That is what we typically call unit cost trends. Second is the number of services that are utilized, which is utilization trend. And three is the mix of services, whether it is changes in site of care or new technologies that are introduced or the like. For our 7.2% total trend, this breaks out to 6.1% for medical and 10.7% for pharmacy. This is largely driven by unit cost increases. As we compare that to what we had previously filed, our previous filing used a different experience period to projection period, and our current filing is a slightly higher trend rate than what was previously reviewed and approved. This means that our experience trends that were used in our previous filing were slightly understated based on the provider contracting changes that ultimately emerged over the course of time. As we look toward determining our future trends are taken based on a best estimate basis of what we expect provider contracting to be in the coming year. And it is also reflective of changes in the market. If you think about pharmacy, it includes future expectations of drug price increases, new drug approvals, new generic entrants, and changes in drug mix, as an example.
Okay, thank you. There are several Connecticut assessment items listed in your actuarial memorandum, which you mentioned in your opening statements, but they were also not listed or reflected in your original or previous filings. The largest items include the Connecticut Department of Insurance assessment, Connecticut annual immunization vaccine assessment, and Connecticut public health fee. Can you explain why they were previously excluded?
Each state is different in terms of the assessments that they require, and entering a new state is challenging and complex. The 2023 rate filing is our first opportunity to correct the fact that we did not include these assessments in our initial rate filings, as they came to our attention in 2022 as we started to pay out these assessments related to this block of business. While we cannot recover the costs associated with 2021 or 2022, we believe that we are appropriately reflecting these for our 2023 plan year.
Can you please explain the 5.7% increase in the 23 rates over the 22 rates due to the emerging experience that you mentioned also in your opening statement?
Yes, so in 2021, we had 15,000 member months, and we have taken the opportunity to reflect the experience of those customers. Their experience was elevated based on from the projections that we were expecting. We are not placing full weight on this experience because we do not have enough membership and enough experience to meet our credibility thresholds. And therefore, this contributes to 5.7%.
Do you know what the weight is you're using on your experience?
We are applying 39% weight to our experience and 61% weight to our manual.
And in previous filings, you would have filed all manual rate, correct? So it's really the shifting, just as you get more experience, we'll be giving more weight to your members.
That is correct.
Okay. I believe I'm done for the Cigna questions. I will move now to the Connecticut questions. Oh, Paul, did you have any follow-up questions for Cigna?
I did. Can everybody hear me?
Thank you.
Okay, great. Thank you. And thanks, Tricia. I did have a couple of follow-up questions. I wanted to dig in a little bit more to the last couple pieces of Tricia's questioning and ask some follow-up questions. I think you identified that for the CSRP program, you were a net payer into CSRP for the 6 months of experience for 2021. Is that correct?
That is correct.
And you're using a 50-50 assumption that you'll continue to be a net payer in 2023?
That is correct.
Okay, even though that's not very credible data. So I guess if you can explain a little bit more on the 50-50 split with just the first 6 months of you beginning in the marketplace and why you would be assuming in 2023 that you would continue to be a net payer.
Sure. So there were 2 reasons that we took this approach. The first reason was related to the fact that we were indeed a net payer in 2021. because we do not, to your point, have a long-running history in the small group market here in Connecticut, and we do not have, we are not as established as some of the other carriers. We then looked to the other publicly available rate filings, and we looked at what other net payers have experienced in their time in the market and view that as a more credible expectation based on the assumptions that I just laid out.
You're absolutely correct, but there are also net receivers. So I'm wondering why you didn't specifically look at why your book would continue to, I guess the question I have is, why are you assuming that your book will continue to be a net payer in the future? That's probably a better way to ask the question.
With only 6 months of experience in this program, we view our approach to the rate development process as aiming to make sure that our rates are neither excessive nor inadequate. And this, to us, seems like an opening where there is more risk if we get that wrong, where we need to make sure that we are covered in the event that this continues. For the experience that we had in 2021. It's an assumption that we will continue to monitor and determine in future rate filings.
Okay, thank you for that explanation. The last follow-up question I have for Cigna, I'd like to better understand the adjustment for the worse than anticipated experience that you saw for the first 6 months. I think Tricia mentioned it was a little over 5% that impacted your rate increase request. And I understand that you're applying a 39% credibility factor to that. How many member months was that for 6 months of experience?
We had over 15,000 member months in 2021.
And that would generate a 39% credibility factor?
Yes, we use the limited credibility approach, limited fluctuation credibility approach at a 100,000 membership level for full credibility. And that computes to a 39% weight on our experience. We want to make sure that we are reflecting the experience of our customers, whether it is favorable or unfavorable, as we view it in the light of how we expect 2023 to emerge.
Okay, and do you have any general explanations of what you missed on your initial pricing? Because if you recall, when Cigna submitted their rate filing, the insurance department did not adjust your initial rate filing for the first 6 months, for the last 6 months of 2021 when you entered the market. So where do you think you missed with regard to the assumptions you used for those last 6 months of 2021?
We continue to explore the drivers of our experience, and we believe that the way that we have priced for 2023 makes the appropriate adjustments to our experience that emerged in 2021. From a perspective of what would we have wished we knew going into this rate filing process, entering into any new state is a complex and challenging process. For instance, those state assessments that I mentioned before of things that we missed. The actual experience of our customers was elevated versus our expectations with higher inpatient and high cost specialty drug costs. Those are things that we will continue to monitor as we continue to add new membership in the state of Connecticut and continue to shift toward experience rating in the future.
Thank you for that. One last question, Sarah. What does Cigna assume for a risk adjustment? Are you considering yourself a risk adjustment receiver in 2023, a payer, or is it net neutral?
For risk adjustment, we are assuming a net neutral position for risk adjustment.
Okay, so I hate to belabor the point, but you're assuming a net neutral for risk adjustment, but you're assuming a 50-50 that you're going to be a net payer in 2023. I guess it help me better understand that, because it seems to be a little bit contradictory. I think if you think you have a worse than anticipated block of business from the average marketplace, then you would anticipate that you would be a net receiver of risk adjustments in 2023. I just help me connect the dots there.
Sure. So the risk adjustment program and the reinsurance program are based on different measures of the risk of the population. The risk adjustment pool is related to the underlying risk and health status of the customers that we cover. The reinsurance pool is specifically related to customers that have $300,000 to $1 million in costs over the course of a year. While the two programs may be correlated, they also may not be in the long run. And so I think we need to look at them separately. From a risk adjustment perspective, we do not yet have enough experience in the market to assume that as we continue to grow and take on more market share, that we will have anything but that neutral risk adjustment position. Related to the CSERP program, we continue to anticipate, based on the two reasons and approaches that I outlined, that we see no reason that our net payer position will change. And based on other publicly available rate filings from more established carriers in the market, we believe that the 50% recovery rate is appropriate. One thing.
Okay, thank you for that explanation. I'm all set, Tricia. Thanks.
Okay, thanks, Paul. We had a follow-up question. No, never mind. We'll move on. So I'll start. Thank you, Sarah and Paul. We'll move on to questions for Connecticut. Just as a recap on Connecticut, Connecticut filed 6 filings, both on and off exchange, individual and small group filings. The average rate increases ranged from 22.9% to 29.3%, and that also varies by plan also. Connecticut, first question, based on that request amounts that you're asking for, can you just give a quick detail on the major components contributing to the large rate increases?
Sure. So the most significant driver of our proposed rate increase is the requirement to get rates back to an adequate level. As Ms. Moran pointed out before, we lost over $65 million in the individual market last year, which demonstrates that the current rates in 21 and we expect to lose more in 22, those rates are inadequate. So over half of the requested 24% rate increase is due just to getting rates back to a level that we can sustain going forward. The second biggest impact is due to trend. We've heard some discussion of trend, and I'd be happy to go into more details on that. Those really, drive the majority of our increase. There's some puts and takes on some other items. State mandates, a small impact there, small impact due to COVID, and administrative expenses going up, offset somewhat by changes in some of our negotiated rates, what we call non-fee for service expenses, which are like capitated expenses, where we're paying a fixed amount in securing services from vendor. And we've been able to get some of those costs down. Pharmacy rebates have also increased, so we can lower our rates that way as well.
And when you talked about the inadequate rates, are you talking about the experience in 2021?
Yes,
And then,
and in 22.
I was going to ask, how was 22? Okay, so you're saying
Yes.
the rate, they're still seeing the claims coming in at the same level, 22?
Yes, yes.
Please explain, well, based on your base experience here is for the 2023 rates is 2021. Please explain any adjustments to the experience here to better reflect projected 2023 experience, including the cost for vaccines, testing, and treatment for COVID.
So when we built up our rates, as you stated, we started with the 2021 calendar year experience. We did adjust for COVID. That experience that we started with included the claims related to COVID. We then reduced that experience to strip out the cost of COVID or the impact of COVID. And that impact was about a 5.5% increase in claim costs in 2021. We took that out of our baseline experience. There was a factor in our filing of 0.945. From that experience period, we then applied trend going forward, and that trend excluded any impact of COVID. It was what we would see normally through impact of utilization, unit cost, service mix, et cetera. And then that got us to 2023. That was a 2-year trend. And then we added on the anticipated cost of COVID related to vaccinations and testing, et cetera. And that was a 1.5% increase in our impact in 23. So again, just to reiterate, we started with experience that included the impacts of COVID. We normalized by removing COVID because that was a one-time impact in 21 that's going to be different in the future. We trended forward, and then we added on an increment for the expected COVID in 2023. Just to give you some idea of where that increase came from, it was 1.3% in 23. About 0.4% of that is due to treatment, 0.6 due to testing, and about 0.2 related to vaccine. So it's primarily testing and then some treatment and vaccination.
Yeah, and to just confirm, so the two adjustments, one was to remove the COVID costs from 2021, and then you added back in the smaller relative to claims or premiums of 2023. So the net impact for COVID was overall a negative to the rates for those
Yes.
two items. Yes.
For those two items, right.
Thank you. And did you please detail or explain any other changes to morbidity that were made for the experience period 2021 and projecting 2023 rates?
Right. The only morbidity experience or adjustment that we made this year was related to the extension of the enhanced subsidies. When we made our initial filing, and we were transparent about this, we noted that our filing assumed that the enhanced subsidies under the American Rescue Plan would sunset at the end of this year. Some states, our parent company is in New York. We were actually directed by the New York Department of Financial Services to make that assumption in the rates in New York. So that was a common assumption. We were transparent about it. As Ms. Moran pointed out before, we fully support the remove or the extension of those subsidies, because that gets at the heart of affordability for the members and the individuals in the state of Connecticut and across the country. More federal dollars to help them pay the out-of-pocket premium expenses is a good thing, and it keeps people insured, it keeps them in the market. So the assumption was, again, and this was in our filing, it was transparent. We were hoping we would be able to take this impact out, which we now will. We assumed, given that Connecticut has a very low uninsured rate, under 6%, which is very good across the country, we expected some loss of membership and some healthy lives to leave the market were those subsidies not extended. The impact of that, we expected about a 2.5% shrinkage in the market, which would have led to an 80 basis point or 0.8% increase in morbidity of the overall market. And that was based on a study commissioned by the state of New York a couple of years ago when the enhanced subsidies were first put in place. My final comment on this is that when the enhanced subsidies were put in place, we expected a improvement in the experience in the morbidity of the market, and we did reflect that in our 22 rates. So the flip side of what we added into the rates this year had come out of our 22 rates. And as I said before, now that is a done deal moving forward, the subsidies will enhance or stay for a couple of years. We're happy to remove that from our filing.
And can you just give us an idea, if you translate that 80 basis points in morbidity, what that might translate to as a percentage of premium?
That was a percent of premium.
That was a percentage of premium?
I'm sorry, about 60 basis points.
Okay, thank you.
Tricia, if I could just jump in with one quick question here for Neil.
Sure.
And it's related to COVID because I'm not the actuary of a table, so I'm trying to understand this. I recall that last year, certainly for 2021 and for 2022, we did hear that costs would go up because of all the treatment that had been deferred from 2020.
Mm-hmm.
We're 3 years out now.
Right.
2023 is what we're looking at. Should those costs not be declining by now? Any the deferred treatment costs?
It's a very good question, Commissioner, and something that we're looking at in trying to study, with our data as it emerges. COVID obviously was a unforeseen one-time shock, right? In a lot of ways, but in terms of medical cost, we did see services come back fairly robust in starting in the middle of 2020 and through 2021. As was pointed out earlier, we are seeing higher severity, especially in the area of cancer. People coming back in, being diagnosed quicker and at more advanced stages. I do expect that over time that's going to dissipate. And I truly hope that at some point we're sitting here not talking about COVID as a driver of our cost. It's just another thing that's endemic to our society, like the flu and anything else. And I think we're getting close to that point, honestly.
In terms of mental health, your mental health projected costs continue to increase significantly for many of your filings, sometimes in the range of 20 to 40% on a per member per month basis. Can you first clarify if there's a capitation and or no capitation aspect to this cost? And secondly, what do you believe is driving these increased mental health costs?
So yes, the mental health cost for us is capitated. And what that means is that we secured those services from a vendor, and they charge us a fee per member per month, and that includes their administrative costs, right, to cover not just their claim costs but the cost of their business. The capitation rates are set closer to the end of the year. We're in negotiations now for the 2023 rates. So when we set our filing, we're projecting what we think those rates are going to be, looking at our internal data. When we did our 2022 rate filing for this year's rates, that was back in July of 2021, we were anticipating a capitation rate of $15.76. The negotiated rate at the end of the day, in September, October timeframe, was $16.25. So that was a shortfall in what we had baked into our filing. Our best projection right now, based on early discussions with our vendor, is that capitation for 2023 is going to go up closer to $19 per member per month. And I think what's driving that is, again, in my mind, it goes in a lot to COVID and what we've all been through as a society over the last 2 years. Tremendous strain and tremendous pressure on all of us as we've been dealing with an unprecedented pandemic. And that's manifesting itself in a lot of ways, one of which is mental health.
Okay, thank you. Now you do an individual on exchange product. The federal and state officials do continue to allow the silver plan loading to compensate carriers for the cancellation of the funding of the cost share reduction subsidy program, better known as CSR, CSRs. What is your explicit CSR silver load and how do you determine it?
The way the silver, let me define for those who don't know what silver loading is. Back in the original ACA, certain people under, I believe it was 250% of the federal poverty level, were eligible for lower deductibles and lower co-payments than people in other plans or above 250% of FPL. Those initially, the difference between the copay that individual pays and what our premium is based on, which is what's known as the standard silver plan, that differential was reimbursed by the federal government up until about 2 or 3 years ago, when just before rates were finalized by the department, funding for the federal subsidies was removed. So what we were allowed to do and what happened in most states was this concept of silver loading, where we could take the value of those enhanced copays and coinsurance and raise our premium across all silver members so that we're made whole in terms of revenue to cover those enhanced copays. So it's really a shift in funding, if you will, from federal funding to premium. One thing that does, on the aside, is by increasing silver premium, that also increases the tax subsidies that people are getting as well. So it didn't really affect the members per se. It was really just a funding shift. So what we do is when we look at this, we look at, there's 3 different levels of cost share reduction plan. We look at a distribution of members within the silver plans, and we decide how much we're going to pay in enhanced copays and lower deductibles, and then we come up with a load to apply to our silver rate. When we looked at that in the 2022 rate filing, we had an 11.9% load for silver loading. And that's somewhat consistent. The first year we started out, I was looking back at this recently. The first year we estimated it at about 16%, over 16%. It's stabilized in the 11 to 12% range over the last few years. This year, like I said, for 22, it was 11.9%. This year, we're projecting it to be 11.2%. So again, that's a favorable impact on our overall silver rates.
Thank you. In terms of state mandates, consistent with the question I asked Cigna, can you give an idea of the percentage premium impact of some of the more major mandates, including the Connecticut Diabetic Act that was passed 2021, as well as the more recent enhanced diagnostic screening requirements and the mental health for children?
Yes. Bear with me just a second here while I find my notes. Okay. So Public Act 2290 concerning required health insurance coverage for breast and ovarian cancer screening. That act expands health insurance coverage requirements for treatment used to diagnose breast cancer, as well as to clarify that there should be coverage for specific diagnostic and screening procedures based on qualifications set forth within the act. That one had a rate impact based on our analysis of 0.4%. For the other public acts, Public Act 2247 concerning children's mental health, that requires carriers to provide coverage for 2 mental health wellness examinations per year, performed by a licensed mental health professional or primary care provider. And it prohibits prior authorizations for such exam. And in our evaluation of that, we did not see that that would have a material impact on rates. So we had no impact due to that. Back in 2021, the state of Connecticut passed a bill mandating richer benefits for diabetic treatments, such as prescription drugs, medical supplies, et cetera, that began on January 1st of this year. And again, that impact is no different than what we had in the 22 rates. Those were the primary state mandates. So again, over all of the mandates, it was 0.4% impact.
Thank you. And now on to trend. Consistent with the Cigna question, trend is a significant component. Your average annual page trend ranged from 7.4% to 8.2% last year's filings. This year ranges from 12.1 to 17.2 on the individual side. For small group, changed from in the mid 4.6 or 4.7 to 12.5 to 12.9. What are the largest drivers of that? There's 3 parts to the question. What are the largest drivers of increased trend? And the largest driver, for the increased trend since last year. 2, walk through your process that you use to determine that future trend. And then 3rd, 2021, in your experience, appears to have been a very high trend year. Can you just let us know how you factored that into your 2023 projections?
Sure. So yeah, trend, for those of you not familiar or less familiar, trend is how we get from our baseline experience in 2021 to the future year, 2023. So what we do is we look at the experience. We've actually gone back and looked at experience over 5 years to look at it, get perspectives on the components of trend that are important, which are utilization, unit cost, and then mix of services and some smaller items there. As we look at trend over that period, you're right. 2021 was kind of an outlier year, but that was coming off of a baseline 2020 where we had the shutdown due to COVID and a big dramatic change in how medical care was delivered. There was not a lot of medical care delivered between, I think it was March, April of 2020, and then June of 2020. And even when it came back differently. People weren't going and engaging the same way with providers that they were in before. So that explains the dramatic change from 2020 to 2021. As we look at the components, though, we did see a dip in utilization in 2020, about a 7.7% dip, and then a 30% increase in utilization in 2021. So that's the phenomena that I was just talking about, a dip in one year followed by a jump in the other year. Still throughout that, on an average basis over 2 years, utilization was increasing about 12%. Year to date utilization through April, if we look at through April this year over through April in 2021, we're also seeing about a 12% increase in utilization. If I roll that forward to one more month, which is through May, it drops to 8.5%. So someplace in there year to date is where trend is going. And we're assuming going forward about 6%, 6.3% in 22 and 5.4% in 23. So we're assuming in our trend development, a utilization assumption significantly lower than what we've been experiencing year to date. On the unit cost side, Our unit cost is based on what we expect to from our contracts and negotiations with providers. So we've got it just under 5% built in for that both years. And if I look at, this is something we evaluate all the time, where as we're out negotiating, as we lock in contracts, and typically contracts are 2 to 3 year periods. So some of these contracts are already locked in, some we're still negotiating, but we factor all that into a unit cost adjustment. So combined, utilization and unit cost alone supports our trends at 12.6% for this year and 11.5% next year.
Okay, thank you. You stated that you added a provision for adverse events in 2023 pricing. Can you explain the reason for adding that this year? And what is the impact on a percentage of premium for the 2023 rates?
Yes. So so in the past, what we had built into our pricing was a pre-tax profit margin of 5%. That was in all of our filings historically. Last year, the department decided to, in their final analysis, restricted the pre-tax profit and actually to get it under 4%. I think it was 3.75 or 3.95 as the numbers worked out. Part of that margin, and historically, like I said, we had 5% in our rates, but part of that margin was to cover adverse events. It wasn't a profit margin per se. So this year we've decided to clarify that in our filing and put those two components in separately. So we have a target profit margin, and we also have the provision for adverse deviation. As the commissioner mentioned in his opening statements, as actuaries, we're subject to standards of practice that we have to follow. And one of those standards of practice around rate filing not only says that rates must be not excessive, not discriminatory, and adequate, but it also recommends putting in a provision for adverse events. Adverse events are things that happen after the rates are filed that impact experience, but are not contemplated in the rates. So we put something in the rates to cover that. One example of that, and one of the things that drove our losses last year, is in 2021, through the exchange, we ended up with a tremendous surge or churn of business because we had what in effect was a continuous open enrollment period. All right. That allowed people to come in when they needed care, get insurance, cancel it when they didn't. That violates one of the basic principles of insurance, which is people who are healthy, not needing insurance, pay into the pool, and people that need coverage extract money when they get sick. So that actually impacted our bottom line somewhere between 1.5% and 2%. That's an example of an adverse event or adverse deviation. So that's what we're trying to put into our rates this year to just to clarify for the department those two pieces.
Okay, thank you. My last question regarding the CSRP program. As I mentioned in the Cigna, we usually would assume that this would be revenue neutral over time. Can you explain why you're pricing your 2023 rates with a cost associated with the pool?
Yes. And on CSRP, we look back at our experience back to 2018. You may recall that 2018 was the first year of this version 2 of CSRP. CSRP prior to then was a totally different program, but this program now that reimburses carriers in the small group half of their losses for individual claims of between $350,000 and $1 million. every year since 2018, we have been a net payer into the pool. And by net payer, I mean what we pay in terms of the contribution to cover the risk of all the carriers in the pool, plus the administrative fee that CSRP levels on carriers, minus the claim costs. And in each year, we have paid in on average to the tune of $4.12. And we expect that as the small group market shrinks, and we expect that to continue. We've seen that in the past 3 or 4 years. We expect that cost will go up. So that's why it's based on our history.
All right, thank you. That concludes my questions. Paul, did you have any follow-up?
I did, Tricia. Thanks. And thanks, Karen and Neil. Neil, while we're on the CSRP subject, I'm going to ask it a little bit differently, and maybe you can explain a little bit differently what that $4 per member per month is. I think what that is a recognition that Connecticut claims do not fit into that sweet spot for reimbursement from CSRP as much as other carriers do. So you don't get as much reimbursement on a per member per month basis than what is assumed. So for example, if in order to be revenue neutral, you're going to pay in $10 per member per month, and you're going to put claims in there that fit into that sweet spot, and you're going to get back from the reinsurance pool $10 per member per month. That's the theoretical pricing concept, but you're putting $10 in and only getting $6 back.
Right.
So it's a net $4 per member per month loss to you with regard to the assumption that it should be a revenue neutral concept. Is that correct?
That's exactly right, Paul. Overall carriers in the state, this should be revenue neutral, with the one exception of the administrative fee, which is relatively small. To cover the cost of the program. But yes, over the first 4 years of the program, going back to 2018, Connecticut companies have paid into the program $12.7 million and received $8.3 million in claim reimbursements. So there's about over a $4.5 million disconnect between the amount that we're paying in and the claim costs that we're getting out.
Okay. Neil, correct me if I'm wrong, but was it the first year that the program ran that they actually collected too much money, so not enough claims went into this concept and there was money left over in the pool from the assessments? Was that redistributed back to the carriers? The way the program works is we meet, and I'm on the actuarial committee and the board of directors of CSRP, and we meet in June of a current year to settle the amounts from the prior year. All right. So while we gave carriers an estimate of so that they could accrue at year end, we gave them an estimate of how much we expected the cost of the program to be, including the claims. We never charged them that cost as the board of CSRP. Rather, what we did it would have been in June of 2019. We collected all the claim costs from the carriers, and we distributed those claim costs back out and collected just enough money to cover those claim costs. So there was no money to give back per se. It was actually settled after the fact. Okay, so what if there is a year where the assessment created and used for that year is more than what the claims per member per month comes out? What does that money stay within CSERP for future years, which allows you to lower the assessment on an annual basis, or reconfigure the attachment points or the coinsurance? How does that work?
So for the last year that we just settled, it was for calendar year 2021. I forget the exact number of claims, but if CSERP was reimbursing $10 million in claims, we were also charging through a contribution or an assessment. We were also charging $10 million. So for the 2021 year, there is no money to carry over, and that's how it works every year.
Okay.
One of the considerations right now is that the contribution rate has gone up just about every year to settle the prior year's claims. And that's a combination of, as the small group market shrinks, and we've seen this about a 10% decline every year in the fully insured small group market. Oddly enough, the amount of claims that are reinsured within this corridor of $350 to $1 million, those have been fairly stable year over year. So you have a shrinking market, same numerator, same claim cost, which means your contribution rate has to go up. So we, as a board and it has charged the actuarial committee to look at changing parameters for 2023. So we're currently gathering information and trying to do a study of do we raise the $350,000 attachment point? Do we change the percentage that claims are reimbursed at? Ways to control the increase in the contribution rate. But none of that is known or set for 2023. That won't actually be decided until the board meeting next June.
Right. So it's always prospective.
Always prospective.
Yeah.
And as you know, Paul, what we're trying to balance here, CSERP is a statutory requirement in the state. And it was designed to encourage a robust small group marketplace back in the 1990s when small group reform was passed. And it was designed to encourage other companies to come into the market or stay in the market. So we're trying to balance a program that is getting expensive, but with providing some real benefits to the carriers.
Yeah. Okay. I have one follow-up subject, Neil and Karen. It's been mentioned a few times by I think Karen specifically in her opening statements, and Neil, you may have mentioned it, that the department had approved inadequate rates the last 2 years. And I'm going to go specifically back to last year. And you had mentioned, Neil, I think Connecticut lost about $65 million in 2021. Is that an accurate statement?
Yes.
Okay. So I guess when we're reviewing rates for the 2022 calendar year, we are reviewing them in this time frame last year. So we are reviewing from July to September of 2021. And at that time, Connecticut had requested for CBI in the individual market, which has the bulk, 80% of the exchange membership. Connecticut had asked for a little less than 7.5%, and the department approved 5.5%. So we cut approximately 2 percentage points off of that. But I can't help but notice that there's a huge uptick in claim levels. And I think, Neil, you mentioned that maybe half or more than half of the average rate increase request is coming from that huge uptick in claims in 2021. I guess the question I have is when did you find out that the claims had a huge uptick? Because I would have assumed that if you had known that when you made your filing in July of 2021, you would have attempted to incorporate that into your rate filing and your rates for 2022.
Yes, that phenomena presented itself late summer, early fall in 2021, after the rate filings were submitted in July, and about the time that the department was approving the rates. I think that was in early September. So that's when we started to see it manifest itself in the emerging claims. I'd also go back to what I stated earlier about the continuous open enrollment period. We did not anticipate that. That was something that evolved throughout the year. That was not anticipated in our 2021 rates at the time we filed for 22.
Understood. I want to go. So I think it's pretty clear that once the department issued their decisions last September, that we were not made aware of this significant uptick in claims in 2021. So do you have an explanation for what occurred, what transpired that generated this significant uptick, and why weren't you aware of it earlier in the year?
I think there's two components to that. One is a just emerging trend, and as you know, it takes a while for that to manifest itself. Claims, if somebody goes to the doctor today, we may not see that claim for 2 or 3 months. So underlying utilization changes, especially coming out of a pandemic where there's a lot of uncertainty and a lot of changes going on. It takes a couple months, 3-4 months for that stuff to emerge. Okay, so that's the first point. The second point would be that we did have a claim systems change in January of last year. With that came different reporting, and we were looking at data from old system, new system. So it took a little bit of time to wrap our heads around that phenomena as well. So I think the combination of those two things led us to understate what we thought we would need or ended up needing for both 21 and 22.
Okay, so I think it's safe to characterize that rather than stating that the insurance department approved inadequate rates, that based upon the data, the department was not aware that Connecticut was experiencing significant increases in claims in 2021. Is that a fair assessment, Neil?
Yes, and I did not state that the department approved inadequate rates. What we were saying in our statement today was that in retrospect, the rates that were approved were inadequate.
Okay, that's fair. Thank you. I'm all set, Tricia.
Okay, that concludes my questions and any of Paul's follow-up. I'll now turn it over to Commissioner Mays.
Thank you, Tricia. Thank you, Paul, and thank you to the companies for being here. We think it is a very important part of the process that the companies explain their reasons for the requested rate increases. What we will do at this point is to take a very short 5-minute break. We should be back here and restarting at 10:45. And at that time, we will have an hour of questions. We have invited three representatives of the people, the Office of the Attorney General, the Office of the Health Advocate, and the Office of Health Strategies. And for the next hour, they will be asking questions, and we will waive the usual procedures to allow them to ask questions directly of the carriers. So that will be in 5 minutes at 10:45. Until then, this hearing is adjourned. Good morning, all. Good morning, all. We are ready to reconvene. Please take your seats. We are ready to reconvene. Thank you again to everyone who has joined us. Thank you to the companies for being here to explain their request. Thank you to the members of the public who've taken time out of their busy schedules today to listen, to ask questions, whether it's in person or via Facebook or CTN. I do want to remind everyone, if you've already submitted questions, those are a part of the record, and we do review those. And I'm just looking for the email address. If, as you listen, you have questions, feel free to send them in to cid.ratefilings@ct.gov. Now, we are going to try something a little different at this year's hearing. What we wanted was to get a broader array of opinions. We wanted to get more insights. We wanted to get more questions. So what we've done is we've invited, and they will shortly begin asking questions, representatives of the Office of the Attorney General, the Office of the Healthcare Advocate, and the Office of Health Strategy. Each will have 20 minutes to ask questions over the next hour, and they will be allowed to ask questions directly of the companies. To begin, we will turn over the next part of the meeting to the Honorable Attorney General, William Tong. General.
Thank you, Commissioner. And thank you all for being here, and thank you for inviting us to participate. And I appreciate your comments at the outset, Commissioner, that you want to pull everyone into this conversation. Respectfully, I submit that we should start now. I want to note that only 2 carriers are represented here today. There are 4 missing: Anthem, Aetna, Oxford, and United. I should also note that on July 8th, I requested that the Department of Insurance hold a Uniform Administrative Procedures Act hearing. In 2015, former Commissioner Wade committed to UAPA hearings when requests by insurers exceed 10%. A UAPA hearing would give us the opportunity to present witnesses, including actuarial testimony. It would give us the opportunity to examine witnesses, and hopefully witnesses from more than the 2 companies that are here today, and to ask questions of all carriers. And so today, Commissioner, I renew my request that we adjourn this hearing and that the department notice a UAPA proceeding as soon as possible so that we can really dig into these requested rate increases.
Thank you for that request, General. As we have previously explained, 2015 was the last hearing. It was not done again in 2016 because the department then, that was prior to my tenure, but it has continued since, did determine that this hearing, this type of hearing that we are holding here today, is a lot easier for members of the public to become a part of, to provide input, to ask questions, as opposed to, as you know, there are strict procedures governing UAPA hearings. Again, we will take it under advisement, but we are looking forward to a frank and open exchange of views today.
Well, thank you, Commissioner. It should come as no surprise that I don't agree, and respectfully submit that this process is insufficient to getting to the bottom of these requested rate increases. I should also note that the healthcare advocate sitting next to me has submitted questions to Connecticut and Cigna. I believe that Cigna responded, but that Connecticut did not. The Office of the Attorney General adopts the healthcare advocate's questions as our own, and we submit them today. I also have submitted questions from the Office of the Attorney General. I think my staff has circulated those questions. Commissioner asked that those questions and the healthcare advocate's questions be made part of the record, and that you keep the record open until those questions are answered in writing by the carriers.
They will be entered into the record, and the record will be kept open until such time as there is a rate filing made, or 30 days, I think it is, after the record was first opened.
Thank you, Commissioner. Before I begin my questions, I think it's important to acknowledge the context in which we're having this hearing. We're not conducting rate hearings in a vacuum. We're in this room with the industry and actuaries and experts on insurance, much smarter than I am about this complicated regulatory process. But outside of this room is real life. And in real life, Connecticut families are suffering and they're getting squeezed every which way. I'm here today in person to speak for Connecticut's families and residents, because otherwise I fear they don't have an effective voice in this process. Families and residents that are still getting punished by a pandemic that has killed more than 11,000 people in Connecticut. And economically, many Connecticut families are in really tough shape, some in desperate shape. What does that mean? That means that one newspaper reported roughly 650,000 adults in Connecticut are having difficulty paying for basic expenses. 90,000 parents say their kids don't get enough food because they can't pay for it. The price of gasoline, home heating oil, natural gas, electricity is still up. And we pay 13% more for groceries. We paid 13% more for groceries last month than we did a year ago. That was the highest jump since 1979. Rent, housing, all up. And so it is clear that Connecticut residents, individuals in the individual market, small groups, small businesses cannot afford increases as high as 24% on average. For an individual, roughly $100 more a month, $1,200 a year. And let me speak to those small groups, small businesses. Small businesses, if they survived COVID, are still hanging on. And to lard 19%, 24%, 32, 33.2% is too much for them to bear. In this hearing, our priority, our duty should be to Connecticut families and residents and small businesses, to protect them, to make sure they don't have to pay more for health insurance and health care than they have to, and to ask and to even require the health insurance companies here today to do all they can to really serve their customers and not just extract as much as they can pay. Now, no doubt costs and prices are up across the country, and insurers and your employees are paying them too. And I do acknowledge that other states are suffering, but it is clear that Connecticut is different. I have circulated a state-by-state health insurance premium rate increase summary for individual plans for 2023. If you look at this chart, Connecticut rates will see some of the steepest rate hikes in the country, ranging from increases of 8% to as high as 33.2% for specific plans. Our neighboring state of Rhode Island does not see increases higher than 10%. Massachusetts, 15% or less. 16 states show plans that are lowering their rates. By contrast, Connecticut and Cigna here today are seeking on average increases of 24.1 and 19.64% increases respectively. That's why I think, Commissioner, this process is too compressed. We need more time to dig into these rates. It's not a perfect analogy, but as you may have heard, United Illuminating is seeking a roughly 8% increase in its rates, and the Office of the Attorney General will be in front of PURA aggressively pushing back on that increase. That process will take roughly a year, 350 days. They'll open a docket, we'll have a full process, and we really will have the opportunity in that context to dig into the rates. We won't have that opportunity here, and that's why I made my request, Commissioner, that we adjourn this hearing and continue under a UAPA format. That being said, I recognize that our time is short, so let me turn to my questions of the insurers. I'm going to ask both insurers. Let me start with Connecticut. I'm not an actuary and not an expert on health insurance, but my understanding is that an actuarial analysis is undertaken to make sure that an insurance company has enough assets to pay liabilities, right? That's what the analysis shows you. Do you have enough money to pay claims? Is that correct?
That is a consideration, yes.
So do you also do an analysis of whether your insureds, your customers have the ability to pay your premiums?
From an actuarial standpoint, that is not a consideration when we set rates. Our rates cannot be excessive, non-discriminatory, and they must be adequate. Those are the three stipulations or thresholds that the actuarial analysis has to comply with.
Who in your company answers that question or asks that question, whether your insureds, your customers can afford to pay these increases?
I think we're very sensitive to not only our small group and individual clients, but also our large group customers and Medicare beneficiaries. And we want to make sure that our plans are affordable. And as we've talked about, our plans have been the most affordable on the individual market since the inception of Access Health Connecticut. And even with this increase, to get us back to an adequate rate level will remain the lowest. So from that perspective, we have to keep looking at the underlying cost of healthcare and have a broader conversation around the prices that we are charged, which are then reflected in our rates.
Well, thank you for that answer, Ms. Moran. And I appreciate, I did hear you in your opening statement that you have some of the lowest rates in the marketplace, but with an average request of 24.1% and as high as 33.2%, that's going to bring you up much closer to some of your competitors at the higher end of the range. Aren't you concerned that you're going to price yourself out of the market?
That's always a concern. I think for any carrier that's trying to compete in a very challenging market, such as Connecticut, and some of the comments you heard today get to that point. What we're trying to do, though, is maintain a level that is still affordable and still the low-cost option for the vast majority of the members in our plans.
Let me ask Cigna, have you done an analysis of the ability of your small group, small businesses to pay these increases?
So what I would suggest there is that it's the competitive market that really helps to determine whether our rates are affordable. And as I mentioned in my opening remarks, coming into the market just 2 years ago, we have already been able to demonstrate 18% market share. We came into the market under a good faith to provide a more innovative, a more affordable product. And in my opinion, the small group market is responding quite well in the fact that we have gotten to that level of market share in just 2 short years.
So the answer is no. Nobody at your company asked the question as to whether your small group, small businesses can afford these increases.
As I said, we look to the market to answer that question.
So we heard a lot about trend. This is a new concept for me. So if I trip up on some of these technical concepts, I hope you'll forgive me and help me understand them. But trend is your forecast. The baseline is the difference in experience from one year to another. And trend is how you get to the future, right? How you anticipate costs rising in the future. I think that Anthem indicated a trend of 7.2%. We have trend for Cigna at 9.2% in the summary, I think, that you provided to the department. But Connecticut has a trend of 12.1 to 17.2%, depending on the plan. So my question is, why is trend so different for Connecticut?
So trend reflect when we look at trend, and you're right, trend is separate from baseline experience, right? Baseline experience is the starting point, and then we trend 2 years going forward. So when we assess trend, we assess it in the components, utilization and unit cost. Those are the two primary components of trend. If I look at Connecticut's emerging experience in 2022, I'm looking at year-over-year changes of utilization anywhere from 8.5% to 12.2%. I'm assuming in our rates 5%. So I'm assuming that things are not going to be as bad going forward or high trend going forward as we are experiencing. And I think this is the pent-up demand curve coming through, and then should be lessening as we go forward. So again, I'm experiencing 8.5 or 12.2%, and I'm assuming 6% on average going forward for 2 years. The unit cost is really based on our negotiations with providers and hospitals. That's our cost of inputs. That's the cost of goods that we buy on the open market, if you will. And those are going up anywhere from 4.5% to 5%. So those two facts get me to the trend numbers that you see in our filings.
But I guess I don't understand still why your trend is materially higher than your competitors in the marketplace. I mean, does COVID affect your insureds differently than it affects other insureds?
I think it can. Our business is primarily in the individual market. That's where most of our business are. So that's the ACA market. You've got people of all economic backgrounds and what have you in that market. They behave differently than others. So yes, COVID has affected different communities different. So yes, that could be a key driver.
Do pharmaceutical companies or doctors, hospitals, providers charge you more than they charge your competitors?
I don't believe so.
Okay.
But we don't have insight into what they're charging Anthem, Cigna, United. We know what they're charging us, and we know on average, where we feel our discount level is in the market.
All right. You mentioned pent-up demand. Let's get to that for a few minutes. I'm looking at Connecticut's actuarial memorandum, page 2. Do you have that in front of you?
Yes.
Okay. It says we have observed a much greater claims trend in 2022.
Mm-hmm.
And the next sentence, this is likely due to pent-up demand, correct?
Right. And
So-
that's what I just went through, right?
And I'm going to stop for a second and ask Cigna. Cigna, I'm looking at a letter dated August 10th from you to the healthcare advocate. Do you have that letter?
Yes, we do.
Okay. On the 5th page, it says Cigna did not quantify the impact of pent-up demand in our rate filing and it did not make any adjustments to our rates specifically due to pent-up demand due to COVID-19. Is that correct?
That is correct.
Are you familiar with the concept of pent-up demand, Ms. Souza?
I am familiar with the concept.
How would you calculate pent-up demand?
Pent-up demand is a challenging concept to quantify because you have to understand what the baseline of services are before the pandemic happened. Then you have to understand what were the COVID-19 related costs. How would you have expected those costs to trend had the COVID-19 pandemic not happened, and isolate what the differences between how costs ultimately came through to what that expectation was and monitoring that over time. It is something that we have observed in other blocks of business. However, because we entered the small group market in Connecticut mid-year in 2021, we don't have the small group Connecticut experience from pre-pandemic 2020, 2021 and going forward to have something specific in our rate filing related to pent-up demand.
Okay, but it's not in Cigna's rate filing.
That is correct.
So let me get back to Connecticut. Did you provide an actuarial analysis of pent-up demand in your rate application?
To be clear, pent-up demand was cited as a reason for our trends. We did not include an explicit assumption around pent-up demand.
Right.
It was explaining why our utilization trends are double digits and we're projecting forward at a lower rate.
It's an explanation
Yes.
of, on page 2, of much greater claims trend. So it's characterized here as a significant driver. Maybe I don't get it, and I'd ask you to help me understand what you mean by pent-up demand. So to me, as a layperson, it sounds like COVID hits in 2020, right? People don't go to the doctor. They delay healthcare treatments. They delay routine healthcare services. And pent-up demand means there are people that could have used healthcare services then that didn't, and we expect them to use those healthcare services in the future. Is that correct?
That's a component of it.
Okay, so if they didn't use healthcare services in 2020, then they didn't make claims. And I think you acknowledged earlier in answering one of the questions that there was a dip in utilization, correct?
In 2020, yes.
Okay. Did you seek a rate reduction based on that dip in utilization?
Our 2020 rates were already set, right? Our 2020 rates were set in July, or filed in July of 2019 and approved in September of 2019.
Did Connecticut at any time come to the insurance department and say, hey, utilization is down, people aren't going to the doctor, they're not seeking healthcare treatment and care in the way they normally would, and we think that we should reduce rates?
Under the ACA, we get to file rates once a year. Once those rates are approved, they are locked into the market. So when COVID hit in 2020 and the medical system essentially shut down for a couple of months, we could not change our rates. What we could do is we could waive copays, we could waive cost shares. We gave, in certain markets, we gave premium holidays to customers. So knowing that utilization was down, we did use that money to put some back into the community to help them deal with the pandemic.
How much sum? Do you have a quantity?
I don't have those numbers
Quantity
in
of it.
front of
Can
me.
you provide that to the Office of the Attorney General?
We can come up with numbers, yes. Yeah.
So again, let me just get back to, from a lay perspective, in 2020, people are at home. We're in the first half of COVID, and people aren't going to the doctor. They're not accessing healthcare services. And then shouldn't utilization have bounced back in 21? And it did, right?
Yes.
And
Right.
shouldn't
And it's
that be
continued.
baked into the 2022 rates and experience?
As I said before, when Mr. Lombardo was asking questions, when we filed our rates in July of 20, I got to keep thinking of the years, in July of 20, when we filed our rates for 2021, I'm sorry, you were asking about 22. So when we filed our rates in July of 21 for 22, we saw some of this coming, but we did not see the wave that came following the submission. And I went through the reasons with that earlier with Mr. Lombardo.
So I'm just going to pick up on what the
If you
commissioner
could please
said
wrap
earlier.
up. We're running over.
I
Thank
will.
you.
Commissioner, I'm going to pick up on your question earlier. You're saying essentially that people didn't use healthcare services in 2020, right? And we have pent up demand that now goes into 21 and 22. And now 3 years later, you expect them to show up in 2023. Is that correct? That's basically what you're saying about pent up demand.
I'm saying that yes, that phenomena is continuing. I'm saying that it's not continuing at the same rate that it was in 21. We are still seeing high utilization increases in early 2022, and I am essentially cutting those in half as I look forward to 2023. So yes, there will be some continued high utilization as people return to the medical system, but I'm expecting that to come down in 2023.
Commissioner, I did hear the clerk. Having served in this building, I understand that you've given us 20 minutes. I'll note again, this is wholly insufficient to ask real questions of these carriers, only 2 of which are present. I'd ask your indulgence for 2 more minutes to ask 1 more question of Cigna, and then I'll stop my questioning.
So granted.
Thank you. Cigna, you serve a small group, not the small group market, not the individual market, correct?
That is correct.
And these are small businesses across Connecticut. Cigna's not a small business, correct?
We do not meet the definition of small group here in
Right.
Connecticut, correct?
Cigna paid through my research, Cigna paid dividends of $4.25 billion over the past 2 years. Is that correct?
So I don't have those figures in front of me, but I have no reason to dispute your numbers.
Well, let me just, based on, I think your rate filing, it appears that you paid $4.25 billion in dividends, 29.4 of surplus in 2020, and 43.9% of surplus in 2021. And so that's a lot of money going back to shareholders and to Wall Street. Is there any reason that you can't dedicate more of your surplus to avoid seeking a 19% increase in your rates?
So I would remind folks of what was talked about earlier in terms of the profit caps that were instituted last year at 3%, which I would recognize as a modest profit margin for this particular product. In the 2023 rate filing, we honored the request for the 3% profit margin, which again, I would describe as modest. We continually use those profits to reinvest so that we can continue to drive the innovation and the programs that help to drive better affordability. We all acknowledge that affordability is a major issue across the country and here in Connecticut, and we need capital in order to ensure that we can continue to drive innovation.
With respect, Ms. Sherry, I'm not suggesting that we deny you capital. I'm talking about excess of capital. I'm talking about $4.25 billion in dividends that went back to your shareholders in Wall Street, and whether there's any reason why those dividends couldn't be repurposed to provide rate relief to small businesses here in Connecticut.
And again, the rate filings that we're here to discuss are specific to the Cigna plus Oscar small group filing, and we went through the actuarial assumptions and the resulting profit margins that were limited to and honoring the request from the DOI.
Commissioner, I'll stop here. With respect, I think it's clear I've just begun to scratch the surface, and I suspect that the healthcare advocate and the Office of Health Strategy also has many more questions than we have time to present today, and I think is imperative that we have the opportunity to question these insurers in a more fulsome way going forward.
Thank you, Mr. Attorney General. And as mentioned, the Office of Healthcare Advocate will be next, and that is Mr. Ted Doolittle, who heads that office. Ted?
Thank you so much, Mr. Commissioner, and I want to thank you and your staff. I also want to thank the Attorney General and his team who have engaged in this in a way that hasn't always been the case, and it's a tremendous benefit to the consumers and families of Connecticut to have your involvement. So thank you so much, and thank you to your team, Tom Ryan and Kara Passero in particular. And I appreciate very much that the questions that we asked and that you adopted will be part of the record, and that Connecticut does intend to file written responses to join the written responses that Cigna has already put on the record. So thank you all for that. I also want to highlight Commissioner Mays in his introductory statement stated that his office and my office are going to be co-hosting on October 3rd a forum delving into healthcare cost drivers. We're going to certainly invite industry, and by industry I don't mean just the insurance industry, but also pharma, hospitals, and other providers. And so that will, I hope, be very eye-opening for the people in Connecticut, as well as the legislators and other policy members. And so thank you, Commissioner Mays, for co-hosting that forum in October with my office. Much appreciated. Thank you, Cigna, for your answers to my questions. I know you're new to the state, and in reading the responses, it's obviously dry actuarial stuff, some of it, but I think there was a little bit of a miscommunication, and you apparently were reading our questions as hostile. You referred a number of times to to information that was proprietary and confidential. I don't think there's anything that we asked for that was fall in that category. You also several times referred to your openness, I think, or at least that's the way I interpreted it, and I'm a glass half full guy, to participate in a further forum to discuss these questions, to the extent that you put out the notion that this is not an appropriate forum to discuss some of our questions, which I don't think is the case. But there is going to be this October 3rd forum, and I want you to note that. So there will be another forum. Also, in several places, you told us that the information might be publicly available. Go look at the APCD. Well, I'm a consumer advocate. So when you're telling the consumers of Connecticut to go look at the APCD, the All Payer Claims Database, I think you have the information close at hand, and it would be much more convenient for you, for my office, and certainly for accessibility for the consumers of Connecticut, for you just to compile that information. Now, in this context, when we're talking about healthcare premiums, and we're not only talking about healthcare premiums, because as we all know, now we're in a high deductible world, which we weren't, by the way, in 1967 when the statute that this hearing is being conducted under was passed. Now we're in a high deductible world. And the medical costs are borne certainly by the carriers in part, but also by the patients and the families. But going into any discussion of this, we have to remember that our prices in the United States are internationally abnormal. They're globally unique. We pay twice as much for quality that is demonstrably equal, or in some cases less, than the Germanys, the Japans, the Australias, the Canadas. So we have to remember that. It is not impossible to have prices that are literally half of what our healthcare spending is in this country. And again, I'm not directing my comments to the insurance industry solely. Most of this money, 85 to 20% of the money, depending on what type of plan, goes to pharma. It goes to the providers. They should be here, Mr. Commissioner. They should be here. They should be here to justify the prices that they're not only making you pay, you carriers pay, but that they're making us and our neighbors and families pay. Because most of the families, as you know, never even hit their deductible. So most families have to pay the full medical expenses. So that's, I'm trying to introduce myself and my way of thinking to you so that you understand that the questions that I posed to you were not some gotcha game, right? It is an attempt to reach out to you, to lock arms with you and to work together in a concerted way. And I praise Karen Moran's comments earlier directed to just that type of collaboration. And I do think that type of collaboration is slowly starting to take root in Connecticut. There's the cost growth benchmark work that has been very positive in that regard, and some other initiatives as well. So let me just, 20 minutes is not enough time. The Attorney General is exactly right. So I just want to give folks, the policymakers at this table and the consumers who are worried about healthcare costs, a little bit of flavor of what's in our questions and where our questions are coming from. So medical costs, as I've referenced, have two components. One component is paid by the carriers. The other component is paid by the families of Connecticut, right? The deductibles, the co-insurance, the co-pays. So when we are looking, Mr. Commissioner, at whether the price of a product is inadequate or excessive, we can't only look at the premium, because the statute clearly states, and I'm going to paraphrase from the statute, that what we're doing here today is under Connecticut General Statute 38A-665, and it says, and this is a paraphrase because I took out some language, but all these words are in the statute. Rate shall not be excessive or inadequate. No rate shall be held to be excessive unless such rate is unreasonably high for the insurance provided. I'll repeat that last part. This is in the statute. Unless such rate is unreasonably high for the insurance provided. Well, the insurance that is provided in all the plans here includes out-of-pocket costs, substantial out-of-pocket costs. My questions, as you know, were in no small part directed toward asking you to report back to us, not just the premiums, which are required and sufficient to determine the inadequate prong, whether you're solvent. We can get all that from the premium, but the statute goes beyond that, okay? It says that you need to provide information as to whether the premium is excessive, whether it's unreasonably high for the insurance provided. The insurance provided includes the deductibles and copays. That is why I urge Commissioner Mays to, when the answers do come in, and I certainly would actually encourage Cigna to revise and extend its written remarks, written answers, but look at that, Mr. Commissioner, because there is no way to determine if the insurance provided is unreasonably priced if you don't also understand the trends on the out-of-pocket side, and what families have to really slap leather for in addition to the premium. We got to understand the premium. And again, the premium is sufficient for the inadequate prong. It's not sufficient for the excessive prong. So that is why these questions are being posed. I also want to say that if your rates are lowered, or if you are building your rates next year and you are paying the internationally abnormal prices as well, right? I'm a consumer advocate. I don't want my consumers to pay internationally abnormal prices, but I don't want you to either, right? And all that goes down. Well, the high prices do go down to the consumers. But I want to suggest this. If the rate is lowered, or if you're building your rates for next year and you understand that you're up against a wall here, you're hitting a wall with one of our large healthcare systems, don't suck it up alone, okay? My suggestion to you is to come to the Connecticut General Assembly, come to the Office of the Attorney General, come to the Commissioner and say, these are the prices we're looking at for 2024, guys. This is what it's going to do. And why don't we have that discussion and partner and ask in a public forum such as this one for the providers, hospitals and pharma to come in and explain and justify the prices that they're charging the consumers of Connecticut. They're also charging you, right? But they're the ones that need to justify the pricing. We've had forums. Representative Wood is here. She had an excellent forum on hospital consolidation as a cost driver. That's the kind of work that we need to do together, maybe even in advance of the next rate filing season. Just a suggestion. I also will briefly in a moment turn to questions, but I take it from your responses already that everybody agrees that unit costs, which is healthcare policy gobbledygook for the price of a given procedure. So unit cost is the single largest driver of our internationally abnormal prices. And year over year is the single largest driver of trend. And I don't like that word because trend is inevitable, right? You can't do anything about it. But no, trend is actually decisions by certain people in hospitals and elsewhere to charge X price instead of X plus Y price, right? It's individual decision, and we need to get into that. We can't just say trend. Trend is a compilation of individual decisions by people, and then they slam you guys. They're a must-have provider, and you guys are up against the wall. Well, we need to know about that. These policymakers sitting here to my left and to my right need to know about that. The governor needs to know about that. And I think we can really work together on this. Let me just open up and I'm not sure how much time do I have left, Mr. Cliff? 9 minutes. Okay. So thank you so much. So I just want to ask for both carriers, and we'll start with Connecticut. Can you tell me what your rate request would be if medical prices were level next year?
So we have about 5% unit cost trend in our prices. So you could say that would come out. Okay. So about of our 24% increase, about 14% is getting our rates back to a level where we're not losing, right?
I understood that.
Right. So then the other 10%, half of that is utilization, half of that is unit cost.
Okay. So right there, that's a 5+% benefit that would accrue if costs were level year over year. Am I interpreting that correctly?
Yes.
Yeah.
Now, there's another component of this, which is service mix, right? It's not
Sure.
just the price.
Right.
And one of the things that that may happen is even if we fixed costs, right? Not saying we're going to fix costs, but if if we held unit cost increases to nothing, revenue out the door is likely still to increase as more services are done, different services are done.
Or there could be population growth or what
Right.
have you. Understood.
All right.
Thank you. Cigna, any comment on that?
So before I respond to your question, I would just like to respectfully address some of the assertions that you made. First and foremost, the fact that our response was hostile. It was not at all intended to be hostile. And actually,
Good to
I would
hear.
say that we complied with a lot of information in a very compressed time period. So I actually would characterize our response as cooperative, not hostile. And then also I'd like to address the assertion around us pointing you to the publicly available resources, inclusive of the APCD database, which over the past decade, we have submitted over 21 million claims, not dollars, 21 million claims, just 2 million last year. And we provide that information to be transparent and helpful as we all address this important conversation around the rising healthcare needs. The cost to submit that information, it is an administrative burden. And if that information is not deemed to be useful, then we should take a look at that as a way to help reduce costs to drive better affordability, because those administrative costs do come into play in our premium rates. So I did want to address a few of those comments. And we do look forward to continuing to participate in forums where we bring all stakeholders together to discuss this important topic. Cigna has and will continue to be an active participation on this topic.
Okay. So for instance, on out-of-pocket costs, I asked you how much you paid in claims yourself, and I asked you how much your families paid in out-of-pocket costs. Why is that not information that you can readily put together, as opposed to my office, which is a consumer service organization? We're not actuaries, right? We represent folks who are fighting a health insurance denial of something of that nature. And you, I believe, and tell me if I'm wrong, I believe there's no way for you to set your rates for 2023 unless you understand completely how many dollars you're going to be obligated to pay in medical claims, and also how many dollars your families are going to be obligated to pay. So how come that is not a fair question?
So I will let Sarah address some of the actuarial assumptions that you're getting at, but I would also just respectfully remind that we're guided in terms of the limits around what we can have as out-of-pocket expenses, copays, deductibles, et cetera, by things like the AV limits within the ACA. So there are boundaries that we absolutely comply with. And also, as Sarah indicated in her opening comments, we provide many ways through our plan designs that individuals can drive affordable out-of-pockets, $0 copays for virtual care, $3 copays for many maintenance medications. So we are constantly looking at ways to provide plan designs where individuals can absolutely lower and reduce their out-of-pocket costs. Sarah, I don't know if you want to have a little bit more specificity on.
Sure. So as Wendy alluded to, there are bounds by which we have to create the plan designs that we offer. In the ACA regulated marketplaces, we provide bronze, silver, gold, and platinum plans. Cigna offers 20 plans across those 4 metal levels, and we are bounded by exactly how much in cost share needs to be expected from plan customers versus the plan paid expenses. From that, we do in our rate filing include an estimate of what we expect out-of-pocket costs to be for customers in the state of Connecticut for 2023. That figure is $1,860 per year. One other thing I would like to point out is that for our 2023 plan portfolio, we did not raise a single deductible from 2022 to 2023. We are looking for ways to make sure that the offering we provide to our Cigna plus Oscar customers is simple, predictable, and affordable.
So thank you for that answer. So the 1,860, that was the experience for last year?
That is the projection for 2023.
Okay. So what was the experience for last year?
I would have to go back to look at that information and
Okay.
take that away.
So Mr. Commissioner, right here, this is an example, okay? $1,860, which they have that information, we're readily able to give it to me. I would suggest that if we find out what the trend is for out-of-pocket costs in past years, that's just as important for your decision as to whether these rates are excessive or not as anything having to do with the premium side. So understanding the absolute number of the out-of-pocket costs per member, as well as the trend, so that we can see if the out-of-pocket cost is going up, then that insurance product is less valuable, and therefore that might enter into your determinations as to whether excessive or not. Is what I just said make sense? What I just said to the commissioner, as Cigna folks, either Ms. Sherry or Ms. Souza?
We certainly understand your request.
Excuse me?
We certainly understand your request.
Okay, thank you. I want to be sensitive to the time, Mr. Clerk. Okay, well, I just do want to commend the commissioner for opening up this rate hearing process, for agreeing to co-host the forum. And Mr. Commissioner, you know, your tenure is, I hope will extend for many years to come, but these are significant accomplishments, and you and your staff should be proud that you are exploring new ways to bring more consumer focus and more focus on the price and cost, which in some senses, not all senses, but in some senses, the carriers are just as much victim to as the families in our state. So thank you so much, and I appreciate the time, and I appreciate the time from both carriers here today. Thank you.
Thank you, Mr. Doolittle, and I'll take my mask off here, the state healthcare advocate. And the final section of this, or the final part of this segment, will go to the Office of Health Strategy. And in the room, we have Olga Arma, and wasn't sure I was pronouncing that right. Thank you.
Right.
And she is a research analyst supervisor. And on Zoom, we should have Sumit Sujnani, who was the Health Information Technology Officer from OHS. And with that, let me turn it over to you, Olga.
Good morning. My name is Olga Arma, and I'm the research supervisor at the Office of Health Strategy. And I'm here on behalf of Kim Matone, our Executive Director. Thank you, Commissioner Mays and your staff, for giving us this opportunity to cooperate with the carriers to address this growing problem in Connecticut, which is the growing healthcare costs, which are unaffordable and unsustainable. And thank you for all your work with us, working with Office of Health Strategy to try to control these costs and make life more affordable for residents and employers of Connecticut. So I have a few questions, and actually you have answered some of them through your responses to the department and to the advocate and the Attorney General. But I would like to come to them from another angle, if you would indulge me. You mentioned Connecticut, you mentioned ARPA, the American Rescue Act subsidies as the likelihood of being discontinued, and that you have been encouraged by New York to include that in your rate estimates. So my question to you is, it is a reasonable way of estimating rates for the future, but what if the subsidies are not ended at the end of the year? How are you going to adjust the rates to accommodate this?
Right. So in our filing, we had included 0.8% for the expiration of those enhanced subsidies. And I imagine that when we submit our final rate filing sometime in early September, I believe, that will come out because those subsidies have now been extended. As I mentioned before, while that may seem like a relatively insignificant or small adjustment to a 24% rate increase, that is because Connecticut has a very low uninsured rate. So as these subsidies impact the population participating in the market, it's going to have a relatively small impact overall. But we did think it was important to call that out in our rate filing because that was an assumption. And we wanted to be explicit about that because we felt that, you know, there was going to be a decision made about those subsidies one way or another. And while we had hoped that they would come out and are happy that they are being extended now we can take that out of our rate filing. What, you know, the bigger impact, I think, is in Ted, who along with me serves on the Benefits Committee of Access Health, knows this. When those subsidies were enhanced a couple of years ago, we saw a significant movement of people from bronze plans to silver, which I think overall was a good thing. One of our concerns going forward was that we would see, had those subsidies expired, we would see people buying back to a bronze level plan. All four of these subsidies being extended, I think it's good for the marketplace. It's good for the health of the communities that we serve. So I'm glad that we can move forward on that front.
But the impact will vary from market to market, right? Individual or group.
Right. The enhanced subsidies only affect the individual market. They do not affect small group.
They don't, okay, all right.
And they're only available on the exchange too. There are some people that buy individual insurance not through Access Health, and it will not affect them.
Okay, thank you. And then I have another question on the rate increases that you're providing by provider type. What is the individual increases or reimbursement rate for the different provider types you have? Hospital inpatient, hospital outpatient, professional pharmacy. What is the distribution of the rate increases?
Yeah, if I can have a minute just to pull some numbers up. Okay, so in terms of unit cost, what we're projecting for inpatient, which is hospital and skilled nursing facility, we're expecting about a 5.6% unit cost trend for those. For outpatient services, which includes AMSURG centers, dialysis, home health centers, walk-in centers, about 5.2%. And then for physician, which includes not only doctors, but lab, PT, OT, ST, about 3.5%.
And what about pharmacy?
Pharmacy, we are, let me get another page. Pharmacy unit cost is about 6%.
So in this case, which of these providers would you think is, or would you say is your actual cost driver, the majority cost driver?
I'm sorry, could you repeat the question?
That based on the unit costs that you have for the various providers, or various providers, which one would be your majority cost driver?
I think right now we're seeing, this year, we're seeing a shift to the outpatient service categories. Some things so that would be an area that to continue to look at, and something that we are looking at. We've seen a shift in infusions and things like that, dialysis from inpatient settings to outpatient settings. So we are seeing some rapid growth in that area, which is one area we're looking at.
So I will thank you. I'll ask the same questions of Cigna in terms of cost drivers and the distribution.
Sure. So if I understand, the first question was asking for what our unit cost trend rates were to move our experience from 2021 to 2023. Is that correct?
Yes.
We view our trend rates more holistically and look at them in aggregate for medical and pharmacy. So on the medical side, our unit cost trend is 3.5%, and on the pharmacy side, it's 8.1%. In aggregate, our total trends is at 7.2%, inclusive of both that utilization and mix factor, as well as the unit costs. As far as the largest contributor to what is driving those trends, inpatient costs continue to be a preponderance of what we are spending our dollars on. However, the comments that Neil made in regard to more shift to outpatient care and changing the site of care for many services is something we continue to monitor and look at. Also, I want to pause and take a moment to circle back to one of the Attorney General's comments from his segment. I seem to recall you might have mentioned that our trend rate that we filed was 9.2%. It was 7.2%. So I did just want to correct that on the record. Correct. And Wendy just made a note. I don't know if everyone heard, but that was the lowest trend rate that was filed in the state by the small group insurance carriers.
So in both cases, you're saying outpatient costs rising, and this is what you actually want, right? You want people to use more outpatient services than inpatient services because they're more expensive. But then you want them to access timely care because we're talking about pent-up demand here. So what are you doing? What kind of tools are you providing your enrollees to help them understand the increase in costs and accessing timely and preventive care to help with the cost issue?
So from Connecticut's perspective, one of the things that we do is make available to our enrollees access to all of that detail. So if they needed to understand how would this service impact me from the perspective of my deductible, my out-of-pocket, we're able to provide that information. And because we are very local and all of our clinical teams are regionally based throughout the state, that helps our consumers actually navigate the healthcare system, which is unique to their geography. And as we all know, Connecticut is very diverse throughout the state. So it's important to make sure that our care managers are providing culturally appropriate, language appropriate, and condition specific triaging to the right care at the right time. And this is something we spend a great deal of time and focus on, is making sure that that tool is available to our consumers. That can be accessed online via phone, as well as through our Connecticut centers throughout the state, where our members can actually just walk in and ask those kinds of questions and get guidance on how to find care.
Are you actually seeing them use those services?
Yes.
And can you quantify how that has reduced cost?
I don't think I could specifically quantify how it's reduced costs. I think our goal is to make sure that people have the right tools and the right access to figure out how to navigate the system, because it is fairly complicated, and what the impact might be to them if they were to seek care in one place versus another on their individual plan, especially back to the point regarding out-of-pocket costs and the deductibles, which many of us are in.
Thank you.
Sure.
I'll ask Cigna the same
Yep.
questions.
Great, thank you. So many things that we're doing to help guide people to the most affordable care options. I'll start with preventive because that was part of your question. So similar to Connecticut, we are doing a tremendous amount to ensure that folks are aware of the preventive care benefits, which, as we all know, come at a zero copay. On our broader book of business, I'm proud to say that we are seeing our preventive care rates go back to pre-pandemic levels. So that is actually an indication of our efforts to continue to encourage the use of preventive so that we all can help with the rise in what we're all seeing in terms of severity due to lack of preventive. Other things that we're doing, promotion of our digital first approach, virtual care visits at a $0 copay, again, providing individuals with access to affordable care when they need it. I would also highlight our provider directory, which has a wealth of information to help individuals navigate, which we would all agree is a complex system, but it helps to bring to the top of the directory high-performing providers so that individuals are able to find those very easily right there on their smartphones. So those are a few examples of the things that we are doing.
Are you able to quantify the savings related to this?
So what I would say is that while I'm not able to quantify the exact savings of just one thing, right? Because this is a result of many different things. I would go back to what Sarah appropriately corrected on the record, which was the trends that we are bringing forward are the lowest among this small group marketplace. So I think that, again, that speaks to our efforts and the results of those continued efforts to drive affordability.
So those preventive care actions or services that your enrollees are taking up, how is it that you still find increases in the severity of their illnesses? You would think that because they are going in for their preventive care on a timely basis, then their conditions won't be as severe as we're predicting them to be now.
Yeah, I would say that that's something that we are seeing is that even now, there are people who've not seen a primary care physician in 2 years. We've seen a lot of primary care physicians leave the state, retire. So there's also a labor shortage among medical professionals, and primary care is a big gap. So I think we're going to continue seeing people having that first visit since pre-pandemic and a real holistic routine diagnostic testing take place, and that will continue. So I think we are going to continue seeing new conditions emerge that, to Neil's point earlier, may have been caught earlier and are now a little bit more complex and more severe. So that's part of the reason why we're trying to increase primary care utilization. And what I talked about earlier with making sure that there is clarity on how to register with a primary care physician, where to find one. That's something we're spending a great deal of time on. We're also spending a lot of time incentivizing individuals to sign up for our virtual primary care program, where we can actually give members access to full, true, comprehensive primary care. This would not be confused with a more traditional telemedicine visit. This is, I have a PCP that I only see virtually, which is also very effective when people have, a busy schedule or they're just having a hard time finding access to in-person primary care. So I think we still probably have a long way to go to get people where they need to be in terms of accessing prevention, screenings, and just getting a handle on where they are with their health today.
Will Cigna respond to that as well?
Sure. The reality is preventive services are not used by individuals 100%, right? We are striving to continually work to drive the use of preventive, use of primary care, as Connecticut just alluded to. So that's an ongoing effort. And until such time that we are at 100%, we will still, unfortunately, see late stage cancer diagnoses. But the more that we can get preventive services up, the less we will see these late stage diagnoses. The other thing that I would highlight is our focus on behavioral health. We talked about the fact that we give access to a broad network of physicians. We also have no cost share services available for folks that are going through some very difficult behavioral episodes. And as we all know, right, there is that connection between the mind and the body, which is why our focus is on that whole person health, and that behavioral aspects becomes a core part of any offering that we're bringing forward to the small group market.
Thank you. So I have a question about the premium increases. Connecticut median household income is anticipated to grow no more than 4% in 2023. Depending on the household size, affordable premiums are between 7% and 10% of household income. Currently, about 23% of households in Connecticut have inadequate incomes to afford healthcare insurance coverage. The percentage increases to nearly 70% in the individual marketplace households. What percentage of your members and/or employees do you anticipate may drop coverage due to your requested rate increases?
So in the individual market, with the enhanced subsidies, I don't expect a lot of members dropping coverage as we go into 2023. Those enhanced subsidies, the expanded subsidies, are designed to make their coverage more affordable. And we saw people come in last year. As I mentioned earlier, we actually saw more people buying richer plan designs, which is a good thing because it lowers their out-of-pocket costs. So they're using those subsidies effectively. I don't foresee a great shrinkage in the individual market. A lot of this, comes down to education too. Giving people the tools to make good informed decisions.
So are you, you're saying that's in the individual market, so you're making the assumption in the individual market. What about the group market? What are employers doing? Are they adjusting the kind of plans they're obtaining for their employees?
Can you answer this for group?
From a group perspective, we did not model any significant reduction in the enrollment. We actually expect strong persistency as we continue to grow our market share here. I would just note that there are other options that continue to be available in the self-funded market for small group employers as well, but our filings did not contemplate a significant reduction in individuals with our group product.
All right. I come to the end of my questions. Do I have more time? I would like to yield my time to the advocate and the AG if they have any. Oh, in 1 second. Oh, sorry. I tried. Thank you very much. And thank you for the opportunity to have this conversation with the carrier.
Thank you, Ms. Olga Arma from the Office of Health Strategy. I do have to make one clarification here. I think this is my mistake. I should have made it clear at the start. There are two companies represented here. These were the two that we asked to be here because the rate increase requests were significantly higher than the others. So we thought this would be the best way, given the limited time we have, to really dig into the reasons for these rate increase requests. So I just want to make clear that the other companies were not invited. The other companies, we look forward to your information, to your request for information, to your input, and of course, we will continue to question them. But we thought the best use of our time right now would be to have these two companies here. Before we take another short break, I just want to follow up on something Ms. Arma had said on the mix. Now, if we're going from, there's a whole idea of preventive care reducing costs overall, but let's say we're also going from inpatient services to the exact same service being done on an outpatient basis. That service is presumably less expensive. So if you're seeing that as a direction in the mix, shouldn't there also be the overall health cost, the aggregate health cost, should that not also be reduced proportionally? And I'm directing that to both companies, whichever wants to answer first.
Yeah, so two things happen, right? As more expensive inpatient services shift to an outpatient setting, the trend on inpatient comes down, right? But the trend on outpatient goes up. You do get a net benefit from that overall, but the buckets go in opposite directions. But yes, there's a net savings as things shift to more efficient, more cost-effective settings.
I would echo those comments and note that experience comes through in our experience each year. It is contemplated in the trend rates that we have discussed for how we expect the cost of healthcare to change over time and into the future.
Thank you. And I do want to thank the Honorable Attorney General William Tong, the Honorable Healthcare Advocate Ted Doolittle, and Olga Arma from the Office of Health Strategy for being here. We are going to take another short 5-minute break. We will resume at 12:10. And at that time, if you look around the table, you will see there are a number of elected officials who have requested to speak, and of course, citizens of the state. At that time, we will begin that section of the hearing. Until 12:10, this hearing is adjourned. Please take your seats. The hearing is about to resume. Please take your seats. The hearing is about to resume. And welcome back to the Connecticut Insurance Department informational hearing on the 2023 requested health insurance rate increases. At this point, we will now turn to our elected and appointed officials and to the public. Jim will be our timekeeper and will also call the names of those who have already registered. And after that, of course, if you have not, after we've gone through all the registrants, if you have not already registered, this is a public forum. We are open to hearing from you still. Just as a matter of housekeeping, elected officials will have 5 minutes and members of the public will have 3 minutes to make their comments, and Jim will notify you when that time is drawing to a close. So with that, let me turn it over to Jim Carson, who will call our first speaker.
Okay, our first speaker is Senator Anwar.
Senator Anwar? Let's give the senator a little time to get back.
Next up
Actually,
is,
I'm here.
Oh,
My
Senator
computer
Anwar is
is-
here. Senator, please proceed.
Thank you so much, Commissioner, Honorable Commissioner of Insurance, and Commissioner Mize. Thank you for holding this important conversation, members of the Insurance Department and members of the committee. I'm Senator Saud Anwar. I represent the 3rd Senate District, including the towns of East Hartford, South Windsor, Ellington, and East Windsor. I really wanted to thank all the participants who have been part of the conversation this morning and now afternoon. I speak today to urge you to please reject the request the insurance companies have made with the increase in premiums. And I come from the place where I'm talking on behalf of the community and the community's ability to pay. I'll share a quick little scenario so I put this in perspective. If you look at the individuals who are making about $15 an hour, which is close to the minimum pay, if there's a husband and a wife or a couple, and they have one child, and if they make $15 an hour for 40 hours a week for the whole year, each one of them will make approximately $31,200, and that comes to $62,400. And if they're very fortunate and they're able to get a rental place and a rental apartment for about $2,000 a month, there's $24,000 are gone for the whole year. The insurance, at least some of the insurance companies are charging about almost $1,981.27 or so for the insurance for a month for a family, and that'll come to $23,775 for them. That's another amount that's going to be for the whole year. So this family is dependent on $14,624 to survive, including paying their utilities and food. It is very difficult to survive with that kind of situation. And if we increase this to 20%, they will be left with a husband, wife, and a child will be left with $9,869.71 to survive. This is not, they either will stay cold in the winter months or stay hot in the summer months without having the ability to pay for utilities, or stay hungry. And that's the ground reality for a lot of people in our community. One of the faster growing segments of our community are the working poor. And this is going to be devastating for them. We will see more challenges in those communities. I understand and I appreciate the work that our insurance group has looked at to ask the questions, to look at the justifications. I don't want to go into the justification. I think the Attorney General and our advocates for health advocate has done a great job on asking and highlighting the issues, but I do want to talk from the public's perspective. So for the families who are unable to afford, who are unable to sustain, I urge you to please join me and reject this. And this is not the time. This is not the moment to be able to make those increases. Maybe we'll readdress this in a year when people are starting to get back on their feet. Thank you so much, Mr. Commissioner, and all the members for listening.
Thank you, Senator Anwar.
Next up is State Rep Kerry Wood.
Thank you. Thanks to the Connecticut Insurance Department for hosting this forum and in this venue so that people can participate both in person and virtually. I want to thank Commissioner Mays for opening this forum with a statement on how we all need to be working towards reducing healthcare costs. This has been a main goal of the Insurance and Real Estate Committee over the past 2 years. I'm here to say I'm opposed to the increases proposed by the health carriers. I'm also disappointed in the size of the increases, especially when it compares to the increases requested in other states. Things like unverified assumptions, future market conditions, and unpredictability are not reasons for passing these increases on to customers. There's mixed messaging coming from the health carriers. On the one hand, you're reporting significant profits, and on the other, you're asking for double-digit increases in the small group and individual market. This happens to be one of the most price-sensitive markets where customers are buying into high deductible plans. We, all of us here as legislators, are the ones that have to then go back and explain that to our constituents, which is a very difficult job to do. I do have some questions that were already asked. I'm not asking for an answer now, but I just was curious as to why our proposal here in Connecticut was so much higher than other surrounding states. I do want to make a statement that the subsidies that the federal government is providing should not be included in those increases. I read in the paper and both heard here today that mandates are a reason for some of these increases. And just this past session, we passed 2 mandate bills. One was related to early detection for breast cancer and ovarian cancer, which our data has pointed to that this early detection helps save the healthcare system costs. So I'm confused as to where that disparity is. We also mandated the Health Enhancement Program, which promotes going to the doctor more and being proactive with your health. So this contradicts the opening statements stating that people were going to the doctor less, thus resulting in strains to the system when people are in advanced stages of sickness. So I just would like to understand that better. To the Connecticut Insurance Department and members of our Insurance and Real Estate Committee, if mandates are a valid reason for such a dramatic increase, we have to do a better job at understanding the breakdown of each of these costs and have them available to all members of the committee at the start of a legislative session. We also have to have them, the financial analysis be included when we're writing bills. And I will remind the committee that the last mandate review was done in 2016. It is 2022. Lastly, we are looking to our health carriers to push back on unreasonable healthcare costs. I want to thank Cigna, who recently did this when adjusting for dental costs. You went out and did a market study and saw you were reimbursing at a higher rate, and you are pushing back and reimbursing at a lower rate. I immediately called and said, thank you. Can I see more of this happen? I'll just give you a real life example of something that happened to a constituent of mine. He is insured under a small group plan. He spent a few days in the hospital, received a few pain meds, just a few. One happened to be Tylenol. His insurance was billed over $1,000 for those prescription drugs. When he was discharged, he was charged, his insurance covered about a third of that for a 30-day supply. That is just one thing. I'm sure all of us can go into those stories, but I would hope that you would push back on paying those kinds of costs. Again, I heard about you wanting to be more proactive, addressing those costs, doing what you did on the dental plans would be, I would consider being more proactive. So I'd like to see more of that. Thank you very much for your time.
Next up is State Rep Kate Farrar.
Thank you, everyone. Thank you for the opportunity to have us here today. I want to thank the commissioner and the insurance department and all of the guests. And certainly I look forward, like all of us, to hearing from members of the public. I am State Representative Kate Farrar, representing the 20th District in West Hartford. And I am here today to speak on behalf of my constituents to encourage the department's rejection of these significant rate increases. We've heard in the discussion today that companies are seeking an average rate increase of 20.4% for the individual market and 14.8% for small groups. And, for me, and I think so many of us that talk with residents in our communities, these proposed rate increases are quite appalling, given the record profits by insurance companies, the significant hardship of inflation that is faced by the workers and families in our communities, and as was noted in some of the questions, that potential impact that we might see with the latest Federal Inflation Reduction Act. Now, I know that we've seen the data and the information from our insurance companies that they have experienced record profits and executive compensation at the same time as Representative Wood said that they've proposed these steep increases. And of the 9 insurance companies seeking increases, 5 of the companies saw billions of dollars in profits, stock buybacks, and executive compensation that ranges from $17.3 million to $91.1 million in CEO compensation. This is at the same time that inflation is hitting our Connecticut workers and families who cannot afford another increase, such as increased health insurance costs in their budgets. I was pleased to hear today that many of the companies and the 2 before us do note that the Inflation Reduction Act recently passed by Congress and awaiting the president's signature should reduce some of these proposed increases. But today I'm also here because as a previous nonprofit executive director myself, these health insurance increases very much hit home. I hear from the same nonprofits and small businesses in my district who struggle each and every year to offer these essential healthcare benefits to employees. And these types of double-digit increases, they put even more financial stress on our organizations and businesses who also need to retain and compete for employees in our state. So without affordable health insurance, I cannot see how more people will not be forced to forego health coverage, which in turn we know will result in higher catastrophic care costs and true worse health outcomes. So with all due respect, I do, request kind of a question at this point for our 2 insurance company guests before us, because my constituents have asked me directly and do want to hear from you. How can you substantiate the double-digit increases that we're seeing for workers and families when the companies, CEOs are making millions a year and your businesses overall remain very profitable? Is that something you can explain to us and our constituents?
Should I respond first? Okay. This is Karen. Hello. I would reiterate from our opening statement that unfortunately for Connecticut, that is not the case. We are not publicly traded. For this market, we experienced significant losses for 2021 and expect to have losses in 2022 as well. Thank you.
So this is Wendy on behalf of Cigna. So I would respectfully remind folks that the profits that are being talked about here today are coming from our broader company. We are a global health services company. So those profits are generated from a multitude of services and products that we put out into the marketplace, not only here in the US, but across the globe. And the profits, as I indicated earlier, as it relates to this particular rate filing and our small group offering, are, as I said earlier, the modest level that the commissioner has asked us to bring forward so that we can reinvest. And one last point I would make in terms of the profits that we are making as a global health services company. We are also headquartered here in the state of Connecticut. So as we all know, we are proud to be a strong contributor to the economy of this state and also provide over 4,000 jobs into the state's economy as well.
Thank you for your answers. I do appreciate it. I think was noted by several of the colleagues, my colleagues before. I think there is so much we can do together. I just think we do have to address this true disconnect that not just myself as an elected official, but I'm hearing from our constituents day in and day out about, again, these substantial profits and the substantial increases at the same time you're requesting. And on the way forward, I would encourage that we use a consumer affordability measure, hopefully as a central element of the insurance department's review process. And again, I just encourage full rejection by the department of these specific increases. I really appreciate everyone's time and consideration, and I look forward again to hearing from the public today as well. Thank you so much.
Thank you. Next up is State Rep Stephen Meskers.
I want to thank you for the opportunity to speak today to the Insurance Commissioner and as a member of the Insurance Committee regarding the proposed rate hikes requested for the Connecticut-based insurance plans. As a resident of Connecticut, a state representative, and specifically as a member of the state legislature's Insurance and Real Estate Committee, it's obvious to me that our healthcare costs are on an unsustainable trajectory. We've seen the rising cost of hospitalizations and pharmaceuticals and ultimately of our insurance premiums as we seek to cover our loved ones and protect the residents of Connecticut. As I read through myriad criticisms levied on the Connecticut system and various complaints about unfunded mandates, I'm convinced that those arguments detract from the real story. What is clear to me, having worked on Wall Street for over 30 years, is that the healthcare providers and the insurance carriers have lacked transparency, real competition, and fair pricing for too many years. My constituents cannot go to the doctor and price out any medical procedure that they're about to undergo. I can't understand what negotiating fair prices means when there's no transparency to my constituents for doctor's visits, a prescription, or a trip, God forbid, to the hospital. We can and have to do better. As part of my testimony here, I've included a report from the RAND Institute and one from the House Ways and Means Committee about pharmaceuticals. So that part will be attached, and I'm not going to read into that now. But the one aspect of our failing healthcare system that was addressed this past week, the U.S. signed the Inflation Reduction Act, and I have not heard from our insurance companies today, and they have not recognized that the opportunity that these negotiated drug prices may represent for all of us. I would have hoped that the insurance industry would have supported the idea to have all private plans included in negotiated price initiatives going forward. My major concern as a member of the Insurance Committee has been the lack of input from our health insurance industry regarding government-sanctioned regulations that would, in fact, improve competition, reduce healthcare costs, and ultimately reduce insurance costs for their customers and our constituents. The only half-hearted attempt I've seen the industry engage in is an effort to limit mandates. Mandates ultimately are designed to improve and force coverage for a limited number of medical issues. Mandates serve to make tenable the costs of some procedures and medications that otherwise would be completely out of reach. Going forward, I would ask the insurance commissioner and the health insurance industry to approach the state and federal delegation with specific legislative requests related to the cost of pharmaceuticals and to address the lack of competitive pricing in the hospital industry. I would ask for instructions or guidance from the insurance industry on how we can change regulations to allow insurance carriers to improve their negotiating strategies and to position insurance companies in a stronger bargaining position in their relationship with hospitals and pharmaceuticals. We have to begin to hammer down and lock down the costs of healthcare. You know, the insurance industry provides a vital and incredibly dynamic function in the state of Connecticut. I recognize that. I celebrate its histories as one of the cornerstones of the Connecticut economy. But there is a responsibility and a trust we place on this regulated industry, which is failing us. I ask for specific guidance on regulations that would help open up negotiations with the hospital system, including better price transparency. I realize these solutions must be tackled, some of them at a national level. I am more than happy to lobby our federal delegation to improve our healthcare cost structure. I think the first shot in the long struggle has taken place with the Inflation Reduction Act. Absent real and actionable recommendations from the insurance carriers to create a more competitive market and to effectively control or negotiate healthcare costs, I urge rejection of the proposed rate increases.
Thank you.
Jim, if I could just have one follow-up question, because there was one item that the representative raised that I've been concerned about over the past few weeks, and it has to do with the Inflation Reduction Act. That act, and because of the parliamentarian, the idea that the caps on drug prices basically were stripped out for private insurers, for the private market. Are you concerned that, as with hospital spending, that if the federal government is able to reduce its costs, that will simply be cost shifting to the private market? What can you do? How can we tell the citizens of Connecticut, the 200,000 people that have to buy insurance on the private market, that they're not going to be the ones that have to pay for this?
Yeah, and I thank you for the question. I wanted to comment on this. That is a concern. And I think more broadly, we would welcome these conversations around additional transparency on pharmaceutical costs and hospital pricing, and have a dialogue about how to bring those costs down across the board in the state and, of course, at a national level. So we do think there's a role for government as it relates to trying to set controls and guidelines and guardrails around that pricing, both on the hospital and pharmaceutical side. So we would welcome those conversations.
So I would echo that it's the right thing to be concerned about. But I would also say that that is exactly why we continue to do our part in helping to drive affordability on the pharmaceutical side. So great examples of that would include our continued work on our formulary to ensure that we are always putting the most affordable drugs at the top of that list. I commented earlier around many of the things we're doing to incent consumers to utilize those more affordable drug choices through $3 copays, lower copays, et cetera. So those are examples of the types of things that we can continue to do despite the concerns that you have raised.
Thank you. Next up is State Senator Matt Wesser.
Thank you very much. First of all, I want to thank Commissioner Mace and the Insurance Department for putting this hearing on. While my constituents have seen increases in the price of groceries and gas and many other products, the proposed increases in the price of health insurance before us are vastly higher than any reasonable inflation metric. And so, Commissioner, I urge you and your team to reject the increases. And I want to emphasize that not all insurers are reporting significant increases. And I think that puts extra scrutiny on the two companies who are represented here and on other major insurers that are not represented here, but that also reported major increases. It's important that this forum isn't just window dressing and isn't a one-off, that we embrace public forums to identify cost drivers, that we embrace sunlight, and we ensure that the public interest is ensured in the rate review process. I am pleased to see that the Attorney General, the Office of Health Strategy, and the Healthcare Advocate are at the table today. Moving forward, it's my hope that we can re-examine the rate review process in a variety of respects, and hope that we can address this in collaboration in the upcoming legislative session. You know, specifically with regard to Cigna and Oscar, you know, I've heard the testimony, listened carefully, I've read your filings, and when you entered the market, you specifically lobbied for it as an alternative to a public option for health insurance. We heard that no reform was necessary because innovation and market forces would provide significant relief to Connecticut small businesses. And Cigna and Oscar were able, as the company's representatives have admitted before us today, to gobble up market share. They said this morning that Connecticut is their fastest growing small group market in the entire country. And they have listed various reasons for their low, potentially too low rates, including inadvertently failing to account for state fees and assessments. They also improperly failed to account for pent-up demand in the rates. And we've heard that they've incorporated experience from large group markets to inform their experience in the small group market, but did not do so in all cases, specifically with regard to pent-up demand. Is there any remedy? And does this mistake, do the failures to properly price the product previously fall only on the backs of today's policyholders, or does Cigna have any skin in the game? Should the department look at their overall book of business, at stock buybacks, at excessive executive compensation, and ask them to have skin in the game? And I will just remind you that last year, your CEO made $91 million in compensation. You know, Connecticut, we've heard, and there's been discussion, improperly assumed that there would be a death spiral if Congress failed to pass the Inflation Reduction Act. Thankfully, that assumption was wrong, and I'm glad that we agree that that would have been a very bad thing. But it didn't happen. You, though, have cited mandates as a cost driver. My understanding is that that's not permitted under the Affordable Care Act, that under the Affordable Care Act, mandates passed after adoption of the essential health benefits should not be passed on to consumers and instead are borne by the state. Is that correct?
That is correct under the ACA, but for whatever reason, the state is not funding those, right? So I think there has been a review, not by our company, but by somebody presumably at the state, that says these are not technically mandates under the Affordable Care Act, that these were part of essential benefits. And I think that's the key distinction.
So
I want to go back because I've heard the term death spiral. We never said death spiral. We're committed to this market. We've been committed to this market since it started in 2014. We've been the primary carrier on this market and a good partner with Access Health. And we never said that this market was facing a death spiral.
I know you didn't use that term, and I didn't mean to imply that you had. But that when I saw the description of customers dropping off the market because of higher rates, leading to a smaller, sicker risk pool, that's a term that I've frequently used, described as a death spiral. Obviously, that's not happening, right? Congress is continuing that, and we're pleased to have that. Can I ask actually a question that I'm hoping maybe of relief to some, and I think I heard you speak to it, Ms. Moran, earlier. One question I had was with regard to the individual on-exchange market. Have you looked at what the net cost would be to customers? Because yes, I understand we're concerned about premiums, but overall cost to customers is also really important. You know, one of the things we're doing with silver loading is encouraging people to have more generous plans, but that may be more affordable to them. So is that something that the department looks at? And if so, do you have any comments about the net cost after subsidies and the advanced premium tax credits?
Yeah, thank you for bringing that up, Senator, because I think that gets lost when we start talking about the cost of insurance and the premium rate filings that we're putting in front of people, in front of the department. Because of the subsidies, there's a cap, and I forget exactly what it is, but there's a cap around 7 or 8% of somebody's income, and that's the maximum they're going to have to spend to buy insurance. Now, there's technicalities around that. It's a certain silver plan, et cetera. But the difference between the premium rates that we file and what a customer will actually pay is the tax credit that they receive from the federal government. The rate increases that we're putting on the table today, by and large, are going to increase the tax subsidies. They're not going to hit the pockets of the consumers.
I think that's a really important point. And one thing that I would hope going forward, I heard my buzzer go off, and I want to just summarize in the interest of respecting the committee's, the department's time. It's not the committee's time. I would just hope that we could, at least for the on-exchange plans, look at also making sure that we're disclosing the overall or projecting the overall cost of care moving forward. I think that would be helpful. People get alarmed at looking at premiums, but premiums are just one piece of the puzzle. Looking at cost sharing is important, but also looking at the overall impact of potential subsidies. I also hope that we can incorporate the benchmarking process into this so we can identify a specific cost drivers. And I do want to push back on a couple of things I've heard, specifically the use of the cost shift, the term cost shift. We've seen an awful lot of academic research going back decades that does not find that cost shift is a thing that happens in health insurance. This is peer-reviewed. There's a lot of economic research that looks into it. And unless the department, unless the industry can prove otherwise, I do think we should really speak to specific market conditions that are justifiable. And it's concerning to have things like that projections on the political situation in Washington be incorporated into prospective rates. And with that, I want to thank the department for putting this hearing on.
Thank you. Next up is State Senator Kevin Kelly.
Thank you, Commissioner Mays and the Insurance Department for the opportunity to testify against the proposed double-digit health insurance rate hike requests averaging over 20% that were submitted to the Insurance Department for individual and small business health insurance plans that start in 2023. These proposed rate increases are staggering and infuriating. They show not only the growing damage of inflation, but also the damage of Connecticut Democrats' repeated refusal to address rising healthcare costs. Under the leadership of Connecticut's Senate and House Democrat majority, Connecticut is now one of the most overtaxed and unaffordable states for everything from healthcare to housing. And other states are grappling with proposed health insurance rates averaging 10%, while Connecticut residents are facing increases averaging over 20%, almost twice the national average. Connecticut residents cannot afford more expensive healthcare costs. Inflation is driving up the prices of everything, and insurance premiums are often the size of monthly mortgage payments. We urge state officials and regulators to consider the impact of these rate increases on families who are struggling with 40-year high inflation under the Biden administration and living in a state that grows more unaffordable by the day. I also urge lawmakers, state officials, advocates, and the public to recognize the need for action and collaboration to drive down the costs of healthcare and make quality care accessible and affordable for all. Democrats passed the Affordable Care Act promising affordable, accessible, quality healthcare. After a decade of Democrat leadership in Hartford, that promise has yet to be delivered. While some progress was finally made this year involving healthcare cost growth benchmarking, an idea of Massachusetts Republican Governor Charlie Baker, many more policies to drive down the costs of care were rejected by the majority Democrats, who refused to even hold a vote on these proposals. Year after year, Connecticut Republicans offer comprehensive plans to reduce the cost of healthcare and provide real health insurance premium relief. And year after year, Connecticut Democrats refuse to act. We appreciate today's public hearings and these rate increases and the opportunity to testify against rising costs. But more than that, Connecticut families need legislative action at the state level. The drastic rate filings clearly show that the cost drivers are high inflation and Connecticut Democrats' continued expansion of government-run Medicaid, which makes healthcare prices for every family buying private health insurance more expensive. The rate filings also show the irresponsible approach of Connecticut Democrats place on the affordability of healthcare for Connecticut families on their faith in the dysfunction of our national government to deliver. Although Congress did act to pass the Inflation Reduction Act and extend federal subsidies for healthcare for 3 years, what happens after that? Is the answer from Connecticut Democrats to wait and see like they did this year and again gamble with the affordability of healthcare for Connecticut residents? Is that a leadership strategy? Do nothing and hope Washington bails us out? Or will they finally take up common sense, realistic, bipartisan solutions that are guaranteed to protect Connecticut families now and for years to come? The rate filings also show the damage impact of the Democrats in Connecticut continually focusing on expanding Medicaid as their solution to healthcare affordability. They prioritize expanding Medicaid, a lesser quality government-run system, instead of expanding access and increasing affordability of high quality care for all people. And their actions expanding government Medicaid drive up costs on healthcare even further for everyone else who has to buy private insurance. So the Connecticut legislative leaders favor scrapping the current free market system and replacing it with a government-run public option program. Those in power have refused to even consider other proven alternatives, and some Democrats have even proudly taken credit for blocking our plans to reduce costs. Democrats' partisan politics have repeatedly killed cost-saving healthcare affordability reforms, allowing out of control health insurance premium costs to go unchecked, resulting in the Affordable Care Act's protection going unfunded and unused. The solution to Connecticut's affordability is not more government. A government-run healthcare system would mean less quality care, more taxes on the working and middle-class residents, and would jeopardize over 50,000 good-paying jobs right here in the insurance capital of the world. Government-run healthcare programs such as Medicare, Medicaid, and the VA system are not the gold standard. They involve uncertainty and a one-size-fits-all solution that picks winners and losers. Most people on Medicare also need a supplemental policy in order to cover what they have. We've offered a better way, a way that will show not just to say no to the majority, but have put forward a comprehensive plan to reduce healthcare costs. In recent years, we've proposed reducing healthcare and premiums by 30% for the average family by using a reinsurance framework established by the Affordable Care Act and supported by Governor Lamont. We've also looked at ways to reduce prescription drug costs by setting up Connecticut not only for Canadian drug importation, but also trying to tackle the spread pricing practices of PBMs, and also looking at maximizing pool purchasing with other states and utilizing transparency and data sharing to drive down costs. I'm here today to urge both state regulators to continue and consider the true impact of the rate increases on families who are already struggling, and to demand that the majority party in Connecticut stop blocking the reforms we need to make healthcare more affordable and accessible. Thank you again for this opportunity to speak out on behalf of every working and middle-class family in Connecticut. All families deserve access to quality healthcare they can afford. The rising costs of healthcare in our state have gone ignored for far too long. Connecticut is not affordable, and rising healthcare costs are yet another burden our families cannot take. Thank you.
Thank you, Senator. Next up is State Senator Tony Wong.
Thank you. I'm Connecticut State Senator Tony Huang. I represent the 28th Senate District in the Connecticut General Assembly, but I also am speaking today as the ranking Republican leader on both the Insurance and Real Estate Committee, as well as the Public Health Committee in the General Assembly. I want to thank you for the opportunity to speak today, and it's fabulous to be here in the Legislative Office building instead of the Insurance Department. Nothing against the Insurance Department offices, but the energy and the engagement is palpable. And I think, and I hope that into the future, we will have more of these kind of engagements in which the public, as well as the viewing public, can actively engage in this dialogue to have better understanding, a better appreciation of some of the challenges that we're encountering in our healthcare marketplace. But I have to say that there's still a lot to be desired. As I review these rate increases, I think these outsized cumulative increases, not just this year, but through the course of the 12 years that I've been in the Connecticut General Assembly, it is absolutely unaffordable, unsustainable, and particularly in light of this hearing and many others that I've participated in, seemingly, I use a harsh word, tone deaf of our insurance companies to the struggling needs of residents and small businesses that have to choose between healthcare insurance for their loved ones and themselves versus the economic realities of mortgages, business cost, and the necessary cost of COVID impacted economics, but also inflationary pressures. I think it's really important for the voice of the people to be heard in these kind of proceedings, and not just simply business numbers and actuarial analysis and justification. I think you will also hear challenges and engagements in your actuarial presentations with the outsized executive compensations and the profits to dividends, as well as to Wall Street. It seems to be inconsistent when you don't hear of people in our communities that have to choose between food and mortgages versus paying for their health insurance. There's a tone-deaf disconnection. And I hope we're able, through these kind of hearing process, to make that connection. I think I want to thank the commissioner for his always availability and willingness to hear us on the legislative branch, and to have this hearing today. I think it's a result of bipartisan request to have this meeting here in the People's Building, the Legislative Office Building. But I am somewhat disappointed that we weren't able, as the Attorney General and the Office of Health Advocate advocated, to have a true exchange of information, an expert witness exchange, a rebuttal of some of the actuarial data analysis. I still remember in college, there are lies, there are doggone lies, and then there's statistics. I think it's important to get to the underlying rationale and justification. If not anything else comes of it, it would allow better understanding and a better appreciation from the marketplace, rather than seeing bill increases arrive in their mail every single year, increasingly higher than the year before. And I'm equally disappointed that we weren't able to have that kind of a cross-examination. And as the Attorney General cited, to have a delay in the decision that may come in late September that will affect thousands, in fact, 200,000 policyholders in this state, the very residents we represent and the small businesses that we claim to be the engine of our economy. I think it's important to note that the October 3rd meeting that has been agreed to have that kind of an exchange with legislators, experts, and advocates will have occurred after the rate decision had been made. It's important to note that. To me, it's too little too late from a standpoint of process of transparency, access, and accountability. I would hope that we delay this and have a true vetting of your justifications and rationale. There may be every good reason for that. But right now, we are not afforded that kind of expert exchange. And the decision will be made. However talented and well-recognized nationally our talents at the insurance industry has, the public should have a voice. And unfortunately, beyond this meeting, there will be no other voice. And October 3rd, after a decision's been made, and I'll repeat again, it frustrates me. It's too little too late. And I hope that the committee will consider reevaluating and delaying your decision until we have that October hearing, because facts are a stubborn thing. They help ease confusion, they help ease anger, and they help people understand better decision-making processes. So with that said, I actually had a couple of questions that I would have normally asked from a vetting process to get some information. I think the three questions I had would have been, you cite inflationary cost as a factor to your rate increase request. You've had increases many, many years in the past, never cited inflationary pressures. How does that differ from current year calculations? That's one. Number two, you cite COVID as an additional cost to your rate increases. But nevertheless, we also realize that there were millions, if not billions of dollars of federal subsidies to supplement healthcare in regards to the COVID environment. Where is all that money gone? And as a supplement to that COVID question, your claims should have been much lower, as was mentioned earlier in 2020. And obviously there has been an increase. But at the same time, where has that claim savings gone to from an actuarial analysis? And I think the third ultimate aspect that I would ask the question is, I think was mentioned earlier in regards to cost shifting. Obviously, you see a major emphasis in regards to Medicare funding, and I'm very grateful that Congress has acted to ensure that people are given coverage and their Medicaid programs are there. But I would be very curious from evidentiary and actuarial analysis to see that our growing dependence on Medicare programs through the Affordable Care Act and Access Health is creating a supplement cost on our private marketplace. Maybe it's a myth, but maybe it's a real market reality. I'd love to have that exchange and information to address facts versus fiction. But ultimately, I'm not blaming our insurance providers for everything. You may not be on everybody's holiday list, but I know you have a tenable job to do. And I know that we are in Connecticut, the insurance capital of the world. We have the best of the best talents. You are employers, you are contributors to economy, no doubt about it. But sometimes the tone deaf, the kind of purveyor of saying no to people and the rising rate, it seems to many, many people that you're much more interested in Wall Street rather than the residents and small businesses on Main Street. But as I say that, I look for us as a legislative body to be a solution.
Senator,
Yes, ma'am, sir.
you're out of time.
I'll close by saying, we need to create solutions. It's not just beating up on you today and tomorrow, but to be partners in solutions and working with all the talents that you have within your business world and expertise. And I would say that the Senate Republican has offered a number of proposals in regards to benchmarking, to allow you to look at hospital costs, medical device costs, and to address a comparable data analysis. We also want to offer reinsurance. That is a fact, that is a product that's used throughout the insurance industry to be able to offset your insurance risk and assessment. I think the third area is truly addressing the prescription drug cost. Our pharmaceutical companies need to be on board, but I also say that our PBMs, pharmacy benefit managers, need to be on board. But there seems to be a vertical line, unfortunately, because it seems many of our health insurers also own the PBMs. So there's an additional challenge that you have to muster to really look at your business lines and how you can be part of the solution. Because otherwise, a government-run solution is not going to be benefit to anyone in the state in regards to quality healthcare, efficiency and cost, and most importantly, be able to provide the best affordable, accessible, and quality healthcare for people. Because when you strip it all down, we may have other hearings on issues related to the legislative process, but we're talking about healthcare and the well-being of loved ones and individuals. There can be no price on it, but it's got to be affordable and accessible. So I thank the commissioner for the opportunity to provide the testimony, and I truly hope that there is a possibility of reconsidering that informational session with all the advocates will be held before any decisions be made, because otherwise I would insist and encourage that we would vote no to these rate increases until we get further information. Thank you, Mr. Commissioner.
Thank you, Senator. Next up is State Representative Holly Cheeseman.
Thank you. And I think I probably have 27 seconds left after my good friend Senator Wong listened, but I hope spoke. Thank you. I'm State Representative Holly Cheeseman. I represent the 37th District, which is East Lyme and Salem. And I want to thank you for holding this hearing today. I come to you with someone with experience of actually buying on the individual market. If this were 6 years ago, I would be sitting here as a member of the public. When my husband died and my son and I had to take out individual policies, we were lucky. We were underwritten. And my son, then aged 25, was paying $87 a month. Yes, it was a high deductible plan, but it provided 3 primary care visits with a $15 copay. I paid $267 a month. Fast forward 5 years, my premium would have been $1,000 a month for a Connecticut-only HMO with a $5,700 deductible. I have seen the cost of health insurance. And indeed, having insurance doesn't mean you actually can access that care. Your deductible may be too high. Anecdote is not data. I remember having a dog bite and deciding I was better off putting butterfly strips on it than going to the emergency room, because I would have that full out-of-pocket cost. So I think we have to remember the price our residents are paying, that their families are paying, and indeed the small businesses are paying. We've seen the Inflation Reduction Act pass on additional subsidies. That's not going to help those small businesses in our state who want to do the right thing by their employees, yet are increasingly seeing huge increases and have no alternative but to pass them on to their employees. So I would urge that we look again at these increases. I think they're too high, but I also think, and I welcome that spit it out, girl, that October 3rd meeting, because none of this can be fixed without putting everyone round the table. We are looking at an increasingly monopolized healthcare system in Connecticut with two major hospital groups. St. Francis suing Hartford Healthcare for basically restraint of trade, for buying up hospital practices. How many of you go to doctors who are in individual practice anymore? We have made it virtually impossible, and I include government, because what we demand of the individual provider, they no longer can or want to supply. Our drug companies, yes, we save millions in later healthcare costs, but I was very proud to be part of the drive in Connecticut to cap insulin prices. That's a drug that's been around for a century. Yet why should its price have increased? You look at your explanation of benefits. A $10,000 bill is now $2,000 to the insurance company, and the hospital accepts that in payment. I'm not seeing that they're making an $8,000 loss. So we need a real holistic conversation about healthcare costs and how we keep our residents healthy and safe. We need to look at what other states are doing, whether it's benchmarking, caps on prescription drug price. How do we make it affordable, keep our residents healthy, keep the companies, the insurance companies? We want survival for all, but that doesn't happen without having an honest conversation where we can look at the drivers, look at outcomes, preventable medical errors. But you read between the 3rd and 8th leading cause of death in the United States. Everybody should have skin in the game here as we go forward. So I welcome this opportunity to speak. I look forward to the insurance department reassessing these requests, but I also look forward to that honest conversation where we can actually discuss how to provide affordable health care for our residents that provides quality, accessibility, and affordability. Because that's the goal at the end of the day. And the citizens of Connecticut and everyone who supports them and works for them deserve no less. So I want to thank you very much for your time today, and I look forward to hearing further conversation. Thank you.
Thank you. Next up is State Representative Ann Hughes.
Thank you, Commissioner. I'm State Representative Ann Hughes of the 135th District, Easton, Weston, and Reading. And I want to align my comments with my colleague, Representative Cheeseman before, and especially the Attorney General. Thank you for holding this hearing. It is critically important that we as legislators respond to the public demand at this time. We have passed a number of measures to try to meet the moment of extreme economic hardship for so many families, of unaffordability of housing, of gas, of food and supply costs. And I echo my colleagues in outrightly rejecting this request for what feels like extortionist rate hikes to our public that is suffering. And we are completely aware of the record profits that these companies have banked during this pandemic, even while our public has suffered. And I really want to point out that the subsidies that previously afforded on the Affordable Care Act on the exchange for this year and that have been extended by the Inflation Reduction Act are taxpayer dollars. So essentially we are subsidizing with our tax money these companies that are asking for double-digit rate hikes. And I do not want our tax dollars further subsidizing these companies' profits. I echo the Attorney General's comments. What prevents you from reinvesting some of these profits into making it more affordable for Connecticut residents, for individuals and small companies that are just surviving, like Representative Cheeseman says. We want them to not just survive, but to thrive. And that goes for our healthcare consumers as well. I think what Ted Doolittle said about the normalizing of trends as if it's inevitable is that we have normalized a very complex healthcare system with high deductibles, with high premiums and co-pays and HSAs, and these are very complex to navigate. You need a master's degree in navigation, and often the hardest access for our sickest clients, for our poorest clients, low wealth clients, and our sickest clients. And we've normalized that's just the system. And so everybody's playing that calculation game. If I can afford to go to a hospital or a doctor's visit, because even $2,000 is unaffordable to meet that deductible. And we need to reimagine the healthcare landscape, especially this pandemic has taught us. We're not just looking back to baseline. We want to reimagine normalizing easy access of primary care, preventative care, emergency care when we need it, illness care, screenings when we need it, and reimagine that in a landscape that is easy and accessible and affordable for all the consumers. And it's not that way now. And coming up with these little programs, it's only as effective as maybe as if you have a smartphone. And I don't think that's I don't think that meets the definition of non-discriminatory, because we need to reimagine Connecticut as the healthcare capital of the country rather than the insurance capital of the world. And so I urge, along with my colleagues, that the insurance department reject these double-digit extortionist rate increases. Thank you.
Thank you, Representative. Next up is State Representative Robin Comey.
Thank you very much. And thank you to Commissioner Mays. And I really appreciate the opportunity to speak today, and that for your and your team's commitment to being transparent with this hearing. It's been very, very informative. I'm State Representative Robin Comey, and as Vice Chair of the Insurance and Real Estate Committee, I appreciate the opportunity that the Connecticut Insurance Department has provided us to be more informed about this important healthcare delivery landscape. My testimony today is in response to the 20% average proposed rate filed, increases that are filed by Cigna and Connecticut, who joined us today, and thank you for that, as well as Anthem, Aetna, other plans, and United Healthcare in Oxford for the 2023 plan year. Health insurance is already much too expensive, and for so many of my constituents, they are paying too much in premiums and in the out-of-pocket expenses, and I'm here today to lend my voice on my constituents' behalf. I know many people who work multiple jobs, and they must purchase on the individual market for their families, but they still can't afford to purchase it. I've had difficult conversations with them. I've helped connect them to eye doctors or dentists who might be sympathetic to their situation. I recently heard from a senior who explained that she was making a choice on whether she was going to go without food or health care or prescriptions. They're confused on where to go for help, where to find less expensive care, and what the market is offering them. And I know that these hikes will push insurance even farther out of reach for so many people, young adults, seniors, and young families. I was really interested in the OHS's new tool, the Connecticut Healthcare Affordability Index. And according to that new tool, the healthcare costs for our Connecticut residents became unaffordable when they exceed 7 to 11% of a family's income. And according to the self-sufficiency standard, nearly 1 in 4 Connecticut households is considered to have inadequate income to meet their basic needs after housing, childcare, food, and transportation. In my community in Branford, 1 in 4 residents have inadequate income to meet the healthcare expenses they have. If you're an older payer between the ages of 50 to 64, 73% of individual healthcare plans are unaffordable. The people in my district don't know how to shop around. They can't shop around as far as I can tell, and the prices are what they are. Many people I've spoken with are planning on putting off their care at the expense of their long-term health and well-being. I know young people who are going now without or will go without health coverage entirely. As Representative Cheeseman was alluding to, before I was here in Hartford and had insurance, I was a small business owner and had to buy independently off the market. And I have been in that position where we were contemplating sacrificing our family's insurance policy because it was simply too expensive, and that was for my family of 4. Our goal as a state should be to ensure as many people as possible, no matter their age, their zip code, or their racial and ethnic disparities. So in conclusion, 200,000 people in the state will be impacted by these significant price increases in a time, as we all talked about, where we're least able to afford it. I do not support this. I implore the CID to evaluate these requests in a fair manner with the healthcare consumers in mind, not only because of the current uncertain fiscal environment all across this country, but because it's the right thing to do for the residents of our state. So I thank you again for your transparency, for answering today all of our questions, and I look forward to working together to improve the healthcare system for people of our state. Thank you.
Thank you. Next up is State Representative Tom Delnicki.
Good afternoon, Commissioner Mayes. It's great to see you there. I'm State Representative Tom Delnicki. I represent the 14th District, South Windsor. And I've been attending these hearings since, I believe, 2018. And I have to tell you, this is a much better venue than the old G. Fox building where your headquarters are now. And tremendously better from the Zoom meeting that, quite frankly, was very difficult to get across the emotion, the concern, the need to hold the line on rate increases. It seems to me from the number of times I have actually testified and attended that it's like Groundhog Day, that Bill Murray movie where every time it repeats, here we go. We're going to have a rate increase. It's going to be up here and it's here. And year after year, that's what we end up with. We end up with asking for this and getting this. This has to be the year that we break that mold. This has to be the year where we have the end of Groundhog Day. And it has to be the year that we move forward. We are talking about 200,000 of our friends, neighbors, and folks that we know in our communities. Ask yourself this very simple question. What are the folks that are going to be priced out of the market do? Because in all honesty, we all know there are people, families, individuals that will be priced out of the market, that because of the inflationary tug at their wallet, they'll have to make that choice. Do I get health care? Do I feed my family? Do I put gasoline in the car? How am I going to make ends meet? And that's a very difficult situation to be in. And when you start to think about that, and you think about the 200,000 people that are impacted by these rates, I can tell you, I go to Stop and Shop, and I've never had this happen before. Somebody stops me and says, what's going to happen on healthcare rates? What is the good commissioner and his staff going to do? You've got to get up there and you've got to tell people, tell the industry, tell the commission, tell your colleagues just how this will impact them with their budgets and their life. You know, it strikes me that the insurance industry is killing the golden goose that propels our state in some fashion and endangering those who can't afford coverage. I think the insurance industry needs to take a step back, and they need to take a look at themselves for even contemplating on these kind of huge increases. You know, the interesting thing about numbers is a good statistician can prove anything on numbers. But we have to take a look at lives, at people, and work that into the equation so that that becomes a focal point as much as the numbers. You know, I was shocked when I heard the questions, and the question came up pertaining to how is affordability worked into the equation? How does affordability play a role in determining the rates? And if I hope I heard it right, that it doesn't. And that sent up a red flag in my mind that how can that be? How can that be not be part of the issue, not be part of the equation, and not be figured in? You know, it also strikes me that the Affordable Care Act exchange is becoming unaffordable to many of our folks. And if these increases go forward, it will only make things worse to the point where, and I don't want to see this, average people not being able to afford and not being able to buy health insurance for themselves and their families. In conclusion, Commissioner Mayes, I look to you and your staff to draw the line, stop another repeat of Groundhog Day, and say, you know what? This is the year that we hold the line on rates. This is the year we take a bigger look at the issue. This is the year that we move forward and try to solve this daunting problem. And you're a great man. I appreciate working with you. And I've got to tell you, if anyone can do it, it's you. To put the line and hold the line on rate increases this year so we can figure out where we're going. Because we know where we've been. We know it's been Groundhog Day. And we've got to stop that and break the mold. Thank you, Commissioner. Thank you for the opportunity. And I hope next year we do the same thing. No offense to your digs at G Fox, the old G Fox, but having the hearings here makes all the sense in the world. Thank you.
Thank you. Next up is State Representative Kara Rochelle.
Thank you. And thank you, Commissioner Mace, for holding this meeting and holding it here today. I, like my colleagues, am here to speak out in strong opposition to the proposed rate increases, which undoubtedly will place additional financial burdens on hardworking Connecticut residents, ultimately pricing residents out of healthcare altogether. These four insurers are seeking an utterly unconscionable average rate increase of 24.3% on individual health plans and 21.11% on small group plans, impacting over 84,600 policyholders. Premiums on impacted policies will cumulatively increase by more than $130 million. These proposed rate increases put profits before Connecticut people and put consumers on the hook for enriching wealthy shareholders and insurance executives. The profits of big insurance executives and shareholders should never come before the well-being of our residents in Connecticut. While insurers attribute these needs for double-digit rate hikes to the growing cost of medical care, prescription medication, and increased demand for medical services, the reality is that these same companies are raking in higher profits and revenues, while hundreds of thousands of families struggle with the immediate and dire economic challenges during the height of COVID and well beyond. According to the National Association of Insurance Commissioners' 2022 annual report, the industry experienced a significant increase in net earnings of $31 billion compared to just $22 billion in 2019. Today, families and seniors across the state are still struggling with economic recovery from the last few years and are weathering inflation, which is, killing everybody. Rate hikes would be reckless at this juncture, and insurance companies, frankly, must think that we are unaware of their profits. In preparing for this information meeting, the Connecticut Citizens Action Group released an updated report digging into insurers' profits. The report found that 5 of the companies seeking rate increases gained billions in profits, stock buybacks, and executive compensation. Among the insurers mentioned in the report is Cigna, which is requesting a rate increase of 19.64%. The increase would impact approximately 12,127 policyholders. According to CCAG's report, Cigna saw $5.36 billion with a B in profits in 2021 and bought back $7.4 billion in stocks. The CEO of Cigna received $91.1 million in compensation. In contrast to the billions in profits the insurance companies are enjoying, real people in our communities are being forced to put up GoFundMe pages to pay for care to save their family members' lives. While executives are seeing millions in compensation, people are choosing between getting necessary medical tests, life-saving treatment, and paying for their groceries, putting gas in their car, and affording daily life. I represent the 3rd and 6th most economically distressed municipalities in the state of Connecticut. My residents cannot afford these rate increases. This is about so much more than the comfort of the insurance industry right now. This is about the well-being of our residents. I think about this, and I'm thinking about residents that are saying to me, I know that their family has I have one resident and her brother just died of cancer, and she has the same genetic disposition and needs to go get additional tests. And she's waiting because she can't afford it right now. That holds my chest. I can't breathe when I think about that, because this person's life may be in danger because they can't afford what their insurance company is doing to them. I have another constituent, and he's just forgoing insurance altogether right now because what his company offers is just not affordable for him. This is real life, and this is so much beyond, it's beyond the pale at this point, what this insurance companies are trying to do to our residents in the state. So I urge you, Commissioner Mays, and your team to reject these rate increases. We all work for the people of Connecticut, and we really need to draw a line in the sand and do that right now. Thank you.
Thank you very much. Next up is State Representative Lucy Dathan.
Apologies, my connectivity is not going so well. I'm hoping you can hear me okay.
Yes, we can.
Okay, great. Thank you, Commissioner. First of all, thank you so much to the Commissioner for holding this hearing, and apologies I can't be there in person. It is really important that we have a real thorough review of this, and I want to align my comments with the Attorney General Tong, who said, and also Representative Cheeseman, who also indicated that it's just a bit too rushed here. We need some additional analysis. I was pretty surprised to hear when talking about the profits of these insurance entities and what they're getting on a global perspective, that they are saying that in Connecticut, it's not quite the same. So I would like to push back, and I'd like to understand where Connecticut lies in terms of profitability by products, as well as other sort of segments, so that we could compare those to other states. Because it seems like to me, with this sort of analysis that we're hearing, that there is quite a large amount of profits for these global organizations, but we don't have a good understanding of what this means for the Connecticut segments. I think that would be really beneficial. And I would really like to have some better understanding from these providers on what we can do as a legislature to actually help bring down the cost of healthcare in our state, so that we can ensure that, you are doing what you need to do as healthcare insurance companies, but also what we need to do to really address the root of the cause for this. I think that, when I hear my constituents who reach out to me daily talking about the cost of healthcare and what it's doing to them, and you're talking about a 20% increase, and I don't know many people in the state of Connecticut who've received a 20% increase in salaries over the next, or will be expecting to receive in excess of 20% salary increases over the next 12 months. And as many of my colleagues have said, that this just puts a pressure on families, that they will have to make hard choices, whether they are able to have insurance, or are they going to have to forego something else in their lives, whether it is food or other sort of things that they need to also take on to be able to live. So again, I just wanted to reiterate that I have a lot of reservations about this, and I am very opposed to all of the increases that we're talking here, because I just don't feel like we have enough data to really support these. I think one of the providers did talk about that they expect the number of people to be getting insurance to increase, and still being able to pay these rates. Well, in theory, you would say that because the number of subscribers is increasing, the total number in the pool of insured is increasing, which should help also drive down costs because you're expanding the risk. Connecticut does have a very high rate of people who are insured, and we want to make sure that we are able to do that ongoing. So again, I just wanted to reiterate that I'm very disappointed that we're here having to hear about such large increases, and I'm hoping that we can readdress this and get the total number of increases down to a manageable level. So thank you very much for everybody who has participated today. Thank you to the commissioner for holding these hearings. And I look forward to additional discussions, and I'm hoping that we can push this off until we have this October meeting. Thank you again.
Thank you very much. Next up, we have State Representative Tammy Nuccio.
Good evening. Not evening. Good afternoon. It's been a long day already. Thank you very much for having the hearings today and for letting us speak. I'm looking forward to the October forum that's coming up, partnering with all the players here to try to find a way to make healthcare more affordable. As legislators, we can either sit up here and pontificate about why we think all of these things are wrong, or we can actually dig in to try to do something. I'm more the dig in kind of person. So understanding that we're limited, 5 minutes is not nearly enough time for me to sit down and go over these. And I did look at the rate reviews, but go over them and ask specific questions to each organization on why trends or numbers look the way that they did. So I'm going to propose some questions that I will be bringing forth to the October forum, and also be providing to DOI and in another email with all of my other questions that I've already sent. With that in mind, I am looking at recognizing the fact that, increases in individual and small markets tend to be a higher impact because it's a smaller populace that we're spreading costs over. So we don't get the benefit of having large group experience to kind of make the impacts not as high. So recognizing that we're seeing the market shrink in essence, I'm wondering if reading the utilization volumes, everywhere that I'm looking, I'm pretty much seeing that utilization volumes are back to pre-pandemic normals from a claims perspective. And I definitely understand and recognize the mix is changing, and that we have seen a lot of costs and claims come forward because people were not in hospitals, not getting preventive care, and specifically the spike for higher instances of cancer. I'm wondering where this is going to fall in the CSRP reinsurance market here. If we're going to see higher claims and costs related to cancer, which we know typically are going to fall within that 300,000 to 1 million claim range. Is this going to change your payer receiver mix? I know we talked about that slightly with Cigna saying you are a 50-50 and Medicare saying you're a payer in this. Do you think that this is going to tip your mix in any way? And if so, how have you or have you not accounted for that in your rate requirement? So that's question one that I have that we'll hopefully get answers to later. Both providers that are here have recognized that there seems to be some issues with the C-SHIRP program, the functionality of it, and the mix and spread. So knowing that this market is shrinking and the costs are staying the same or growing, have we at the DOI worked with them to dig into what specifically is driving the increase above and beyond this cancer diagnosis? If we're seeing this shift in shrinking market, higher claim costs, we need to be digging in to figure out what is driving those costs, whether it be through the all-payer claims database or whatever. And then we need to understand what industry is doing to actually mitigate those increases. How are we, as a DOI, facilitating them to provide us the information that we need to be able to price those down? You know, like how are we pushing down on that? I'm also very interested in how the companies are balancing their product lines, because I hear what everybody is saying, and I understand probably a lot more than a lot of the people that are at this table how all of this works. But I think it's fair to get pushback from legislators on behalf of our constituents on the questions of profitability of the entire company line and how we're balancing that as responsible members of society looking to decrease the cost of healthcare. So it's our job to bring forward the voice of humanity here, because a capitalistic market does not recognize the individual. So for us to question the profitability and the compensation packages and everything else is fair as legislators. And it is fair to say, we're going to look at your line outside of just your specific line and say, what is your product line mix? And how is that profitability being factored into the affordability of healthcare? Because it is all combined. We are all part of a machine that starts at a low end of healthcare cost, a mix with PBM, a mix of affordability, a mix of admin, and then from a fully insured market, a very highly regulated profit margin. As you've noted, a 3% cap on profit. The reason profits are so high with insurance is because of all of these things that build into that. If we can control the base of the mountain and shrink it, we shrink that level, that number, all the way up to the top. And that's the imperative piece. That's my thing. So I want to say the last thing as I wrap up is Mr. Doolittle made some very valid points. We need to partner. We need to do a better job on the whole healthcare picture, of which insurance providers make up about 20, insurance company profits make up about, well, profit and admin, 20% of that picture of the 80-20 MLR split. We need to fully understand and educate legislators, providers, and most importantly, the public on how healthcare cost drivers impact what they're paying in premium and how we can reduce that impact. If we reduce the cost of healthcare, we also reduce the cost of insurance, and we also reduce the direct profit margin. I'd like to circle back to express that we are rightfully so digging into the rates and challenging you, the people who have come and the people who have not come because they were not invited, either way, on affordability. We as legislators, we have to be willing to take the same stance that we're taking with you, with pharma and with healthcare providers and network negotiated costs. Otherwise, we are doing nothing more than mouth service to our residents. If we are not willing to step up and do the same level of critical critique on those industries, we are not doing anybody any favors, and we are doing nothing more than pontificating. And I don't approve of that. So I'm hoping in the October forum, we'll have everybody at the table and we can start to actually get down to trying to find a way to make healthcare affordable for our residents. Thank you.
Thank you very much. Next up, we have State Representative Kara Pavelak D'Amato.
Hi, thank you. And can you hear me?
Yes.
Okay, thank you. I just want to thank the commissioner and the department for having this hearing. My name is State Representative Kara Pavelak D'Amato, and I represent part of Bristol, Connecticut. I echo the statements made by my colleague, Representative Wood, and several of my other colleagues as well. And I do urge rejection of the rate increase request, as the impact on individuals and small businesses would be overwhelming. There was testimony about the contribution of inpatient costs to the overall rate increase requests. And last session, we had in-depth hearings. And actually, since then, we've also had continuous work sessions dealing with pre-authorizations and the financial burden they place on providers and hospitals, which contribute to those costs. My testimony here today is that I would find it helpful for insurance companies to have a more active role in looking for solutions to this issue. I hope we can work on finding a solution to the pre-authorization problem that many providers face and streamline the process so that way we can reduce the impact that it has on costs. There was also earlier mention of mandates. And I know the testimony was that they didn't have a large impact. At least that was the impression I got on the rate increases. And a couple of different bills were mentioned, so it will lead to my question. The woman didn't mention breast and ovarian cancer bill along with the insulin bill. But the insulin bill didn't go into effect until January 2022, and the breast ovarian cancer bill doesn't go into effect until 2023. So I was just looking for some clarification as to whether, that there was some financial impact from those bills, and I guess what other bills actually had an impact. I think there was another bill that was mentioned, 2290, but if I could get some clarification on that.
Yeah, the carriers could address that. It was three bills: the insulin bill from the prior year and the two ones from this past year. And again, the filings are made prospective, so they are with regards to the 2023 year. So that's why they were included as part of these rate. I'll ask the carriers to explain on that.
For Cigna's rate filing, we had included for Public Act 2114, which I believe is the insulin bill that's being referenced. We were already administering plans in this manner prior to the bill being passed, and therefore it was already included in our baseline experience and didn't have an additional impact above and beyond what was already in our 2021 and 2022 rates. Secondly, related to the breast and ovarian care bill, which I believe is 2290, that bill will likely have a cost impact, but at this time, we have not yet incorporated that into our 2023 premium rates, and we'll continue to monitor the impact to assess whether it needs to be included in a go-forward basis.
And for Medicare, I'm sorry, the only public act that 2290 impacted our rate filing, and it increased our cost by 0.4%.
Yeah, I do remember you mentioning that number. So some of the figures as far as any future impact, would that be information that you share or put up on your website, or any maybe you can get to us in the future? Because I do find that helpful when we're dealing with bills and the impact they have on individual costs. But just in conclusion, I want to thank everybody for their testimony, and to the department again for holding this hearing. I think it's important, and again, the impact of such an increase, really would be difficult, especially for small businesses. I'm a small business owner, and my family is as well, and I know this is something in helping employees that really impacts us and how we operate as a business. So thank you, everyone, again.
Thank you very much. Next up is State Senator Christine Cohen.
Thank you. Thank you, Commissioner and department members. Hello, my name is Christine Cohen, and I am the state senator for the 12th Senate District in the state, currently representing Brantford, North Brantford, Durham, Guilford, Madison, and Killingworth. I'm here because I'm incredibly dismayed by the significant increases proposed by the industry. I have submitted written testimony as well, so please feel free to reference that during your review process. I was disappointed that the department was unable to delay examination of these hikes as requested by the Attorney General, but I am incredibly appreciative of the process here since that decision to move forward was made. It is important that all voices are heard and understood as the insurance department deliberates over enormous price increases. As have been outlined, the average hikes requested are 20.4% in the individual market and 14.8% for the small group market. As I'm sure many are aware, out-of-pocket medical costs account for about 11% of one's income on average, but that number grows to about 35% for low-income earners, according to the U.S. Bureau of Labor Statistics. These numbers I've cited are based on 2019 and 2020 rates, and we've only seen exponential increases in healthcare costs over the past couple of years. Our residents and small businesses are just regaining their footing after a trying couple of years. The pandemic has left people out of work, facing new health challenges, and shuttering companies that had once thrived. For those businesses that have been able to stay afloat despite these tough times, they struggle to maintain a workforce, to provide employee benefits, and to meet financial obligations. For families, healthcare costs remain a constant burden, some choosing between life-saving drugs or doctor's visits and putting food on the table or paying rent or a mortgage. As was the case prior to COVID-19, but particularly so now, healthcare costs are a constant source of anxiety for many. As a small business owner myself, understanding the burden of healthcare costs, I have been an outspoken advocate of a public option. I know all too well the extraordinary expenses associated with providing healthcare insurance to not only my family, but to my employees as well. As an example, my premiums went up 63% from 2016 to 2019, and my family deductible doubled. This is not an unusual story. We've heard it even today. I hear from small business all the time about the significant costs to their bottom line and the uncertainty in the future. Yet legislative attempts at creating an affordable healthcare plan for families and small businesses receive significant pushback from the industry, with many in the sector rushing to the table, indicating that they can come together to drive down costs and find other solutions outside of a public option. So you can imagine the shock and infuriation in seeing these increased requests. Our health insurance system is neither reliable nor predictable and clearly not affordable. I respectfully request the renewed landscape for the insurance sector, given the passage of the Inflation Reduction Act and large profits reported, be considered, as well as the concern that families and businesses across our state continue to feel weighed down by significant financial burdens. These rate hikes are outrageously high and simply not sustainable for our citizens. Please reject the proposals for any increases. Thank you.
Thank you very much. Is State Representative Kim Fiorello available?
I don't see her on the Zoom.
Okay, that concludes then the elected officials portion of the meeting.
Thank you, Jim. And thank you to all our elected and appointed officials who are here today, either virtually or in person, to share with us their concerns, their insights, their requests. And the next thing we'll move on to will be hearing from members of the public. However, as I look at the time, we've been here since 9. The cafeteria, in case anybody wants something to eat, closes at 2. So what I will do is I will do a 15-minute adjournment and we will resume here at 2. So until 2 p.m., this hearing is adjourned.
Yes, I can unplug it and plug it back in.
Good afternoon, everyone. Please take your seats. We are ready to resume this hearing.
Yeah. Any open mic? Brian? Yeah, whatever.
Okay, and then I'm gonna move JP into the.
Now that we've had the elected and appointed officials, as well as obviously the Attorney General, the Office of Health Advocate, and the Office of Health Strategy, it is time for the public to have its say. And if you have not, I just want to repeat, if you have not yet signed up to testify and you do want to testify, if you're in the room, you can simply walk over to the desk to my left and sign up. Or you can send an email with your name to cid.ratefilings@ct.gov if you happen to be online. If you've logged into the meeting as well and you want to speak, you can just use the raise your hand button at the top of the screen, and you will be called in a few minutes after the end of the testimony of those who've already signed up. Now, I do ask again, if you've previously submitted testimony, please do not simply repeat that testimony, summarize it, and feel free to ask questions. Please limit your testimony to 3 minutes. Jim will be the timekeeper. He will let you know when you are about to come to the end of that period. And for everybody watching, please state your name at the beginning of your testimony. And I will now turn it over to Jim, who will call people based on the list of speakers who've signed up. Jim?
Thank you. First up is Brian Anderson.
Good afternoon, Commissioner Mays. I'm Brian Anderson. I'm Legislative Director of Council for AFSCME. Our 30,000 member union strongly opposes the double-digit rate increases that several of the for-profit insurance plans are requesting for small group healthcare policies. More than half of the requests average 19% or higher. Connecticut's request is just under 30%. That's a stunningly huge increase. Even more amazing is that this same for-profit insurance industry leveled severe criticism at the state of Connecticut's partnership plan a few weeks ago for asking for a 10.5% increase. The partnership plan is a health insurance pool run by the state comptroller. Surely, if the industry land based the partnership plan for a 10.5% increase, it should lead the way by accepting an increase of less than 10.5%. Actually, it's hypocritical for the for-profit industry to ask for anything near 10.5%. The partnership plan is a pool of municipal employees that, if allowed to get large enough, would deliver similar healthcare efficiencies and savings as CHIP, the state employee healthcare plan. There are years that CHIP has had rate increases of 0. CHIP's increases are usually quite small otherwise. It's a shame that the very for-profit insurers asking for these huge double-digit rate increases have taken every step at the state capitol and in the news media to choke off the partnership plan. Labor unions have advocated for the partnership plan to be opened up to small businesses and nonprofits, thereby creating a larger, more cost-efficient pool. Sadly, the Connecticut Business and Industry Association and Insurance Association of Connecticut, the lobbyists for the for-profit insurers, have killed every effort at growing this pool. They've killed every effort of bringing costs down. They have killed every attempt to bring reasonable quality health services to working families. Consider the insanely high compensation that these insurance executives pay themselves. At times, the CEO of Aetna has paid himself in excess of $90 million per year. How does an individual create $90 million a year worth of wealth for his insurance company? If such a CEO does anything short of spinning the straw into gold, he's fleecing his customers, his employees, and his shareholders. Please turn down these ridiculous requests. Follow the advice of the insurance CEOs regarding the partnership plan and grant no hike in excess of 10.5%. Consider the plight of the consumer. Consider what basic needs health care is. And the corporate greed is denying many state citizens their chance to have adequate health care. Thank you. Happy to answer any questions.
Thank you, Brian. Next up is JP Whiskey.
Hi, I'm JP Weisky. Thank you, Commissioner Mays, for holding this public hearing. I am here representing the Health Benefit Institute. I'm also the former Deputy Commissioner for the state of Wisconsin, where I also supervise the rate review team. I would like to note up front that the department's comments around inadequate rates is extremely important. In Wisconsin, our carriers filed inadequate rates for a number of years and had losses in excess of $500 million in the state, which led to one specific region seeing a 100% rate increase, the Green Bay area, and with only one nonprofit co-op left providing that coverage in that state. So it can get worse if you're not careful. In my written comments, I emphasize several factors that have caused significant increases across the state, including COVID, the increased utilization there. Worsening of health is a significant issue. We know for a fact that the number of heart attacks and strokes reported went down significantly, which creates a broad problem. Increased mental health treatment is an issue. Rising medical costs, as we've talked about, are a big issue. Prescription drug costs are increasing over time. And while this is good news for a number of consumers, and we're seeing a number of breakthroughs, in fact, we're working with a carrier that has likely going to bring a drug that will cost in excess of $3 million to the market in the coming years. This also is a significant expense. I'd also like to note that the state's tax policy has created significant issues. When you tax something, people buy less of it. And so there should be some efforts to look at the tax burden for insurance. And lastly, regulatory uncertainty has continued to create issues as we've seen transitions from the Biden administration and the prior administration, and late notice around the subsidies that are going through. Lastly, I would note that there are a number of solutions. We worked with the state of North Dakota and put together a study for the insurance department, which is available on their website, discussing hospital and insurance costs. Happy to chat more about that. And in Wisconsin, we ultimately did some work around a reinsurance pool funded by the state. Roughly $250 million goes into that pool every year and has actually successfully reduced costs and expanded coverage in the market. Happy to answer any questions. Thank you for your time.
Thank you very much. Next up is Holly Hackett.
Oh, hello. Thank you, Commissioner Mays, for allowing me to testify today. I am not going to reiterate everything that all of our legislators have said, the Attorney General and the wonderful Ted Doolittle. I would just like to say, as a person and a consumer and a person with significant disabilities and health issues, that I think it's absolutely ludicrous that a very large, profitable industry is asking the consumers to continue to pay when there is a lot of cutting of the administrative fat that they can do before they should be coming to the commissioner's office and to the consumers to pay. In other words, $137 million in just salaries of the CEOs. Come on, seriously? Let's start trimming their fat there first before you start making costs unattainable for the people who truly need it. And that is people with disabilities, people who are elderly, who have worked their entire lives. And if you want to talk about your Medicare plans, the majority of you are for profit. Ergo, you take advantage of people who are on those advantage plans, and you deny them care. And that is how you make those large profits. So your advantage plans are basically a shell game that injure our most vulnerable populations, which are elderly and disabled. So I think you have done enough damage, and I think the commissioner and the entire insurance should say no to your request, because trim the fat within your own company first before you harm us any further. So many people go without excuse me, I am disabled, like I said, and we're expecting rain, so I am not the best speaker in these conditions. So before you come to us, people don't go for care because your deductibles are basically $5,000 a year, and $10,000 and above for families. So no one can afford to get the care that healthcare should be a human right, period. So look inside before you come outside. Thank you. That's about all. I can probably answer a few questions. I just don't know all of these very intricate words that you guys are using to play the shell game with all of us and your fancy words. Thank you. Thank you for giving me the time to speak. I appreciate it.
Thank you very much. Next up is Dr. Phil Brewer.
There we go.
Oh, there he is.
I don't know if you see me on video. Oh, there we go. Start video. Sorry about that. Yeah, this hearing kind of reminds me of what a senator said once about the Senate. Everything has been said, but not everyone has said it. And I'm going to say something different than anybody before, because I am different in that I actually provide health care. I'm an emergency physician. I've been practicing for 40 years and am just recently going into retirement. And I've been taking care of emergency patients in the tens of thousands over that time, which means I've hopefully improved the health of tens of thousands of people. I know I've saved the lives of probably hundreds of people. And unfortunately, in doing that, I have ruined the financial health of also hundreds or thousands of people. I've said many times that I love what I do, but unfortunately, as a result of what I do, many of my patients end up going into bankruptcy. I have a strong opposition to these rate hikes. If you look at, for instance, just one insurer, United Healthcare, the total compensation for their top 6 executives last year was just south of $200 million. One of the insurance representatives here today mentioned several times that her company operates at a loss, and it's not representative of Cigna, and that's why they should have these hikes in their rates. Unfortunately, it is part of Cigna, and Cigna is in the forefront of being in opposition to any effort to have Medicare for all type system, both nationally and in some of the states that have tried it. The fact that a majority of patients now are in Medicare Advantage versus straight Medicare plans is not because Medicare Advantage is necessarily better. It's because it's the only way to also get drug coverage, prescription drug coverage. And that comes at a cost to the taxpayer of about 20% more than what it costs the taxpayer to insure a straight Medicare patient. One of the things that Cigna is doing right now, and I have Cigna myself, and I've gotten at least 10 phone calls now trying to get me to make an appointment to have a nurse practitioner come to my home to do a health assessment so that he or she can then contact my personal physician, who I've been with for 20 years now and who knows me quite well, so that he or she can tell them about this, that, or the other problem that I have that he never recognized. And actually what they're doing is they are inflating the risk score of patients like me and like everybody that they're trying to get to do this, so that they can weasel even more money out of Medicare Advantage. We need to put our general good, the common good first, and get our insurance companies to at least do what Mr. Doolittle recommended, which is to work together to have the state and insurance companies go to bat together against hospital consolidation and the rising costs for healthcare.
Thank you, Doctor. Your time is
Thank
up.
you.
Okay. Next up, we have Tom Swan.
Good afternoon, Commissioner Mays. Thank you for having me today. My name is Tom Swan. I'm the Executive Director of the Connecticut Citizen Action Group. On behalf of our thousands of member families, I urge you to reject the proposed increases from Cigna and Connecticut being heard today, and the other proposed rates for 2023 not being heard today. The insurance department is not solely responsible for determining the solvency and the ability to pay bills. There is also a function within there to protect consumers, and we urge you to elevate that this year compared to previous years. We've been researching and tracking the 5 health insurance companies who sent Governor Lamont the so-called extortion letter around the public option in 2021. This has been part of our work detailed on Connecticut's 5 Families Facebook page, where we have focused more on the 4 for-profit corporations. Our most recent report analyzed data from 2021 and actually makes the case that we should be considering refunds for policyholders instead of rate increases. Some key data points from the report. Anthem, we're not hearing today, but now Elevance Health had over $6 billion in profit in 2021, over a 33% increase from the year before. Cigna did over $7.4 billion in stock buybacks, as if the 91 million David Cordani took home wasn't obscene enough. On a June call with analysts, the company bragged how they already had bought over $3 billion in buybacks this year, and we're on track to exceed $7 billion again. Meanwhile, we continue to see patients out-of-pocket expenses rise. They went up over 10% in 2020 and are expected to continue at that rate for at least the next 5 years. These increases are after the pandemic proved the inadequacy of private insurance and their limitless greed. Insurers got the federal government to pick up the cost of testing and treating COVID while getting Congress to increase premium support so more people buy their product, despite their total failure to adequately help policyholders navigate the crisis. They did not distribute masks, nor have community health workers proactively educate people on how to stay safe and access the care they may need, including mental health. Their behavior during the pandemic almost writes an updated version of Naomi Klein's shock doctrine all by itself. We recognize that we need stronger tools to rein in the greed of healthcare corporations and that the current regulatory construct does not protect patients. That is why CCAG supported a public option and am so disgusted at the hypocrisy of the representatives and senators who opposed that to come out against these increases today. Health insurers are not powerless when it comes to increased costs, as they like to make believe to all of us. Instead, they should be viewed as the heads of a cartel-like entity that looks to maximize profits while blaming providers and drug companies like a Three Stooges skit. Hospitals and big pharma are not innocent players, but insurers play a central role in skyrocketing costs. To argue differently would ignore how most large insurers operate their own pharmacy benefit managers that create many internal conflicts at the expense of patients. United Healthcare has the largest number of doctors and nurses on payroll. CVS Aetna has the 4th most. CVS Aetna is ranked 7th, United 8th, Cigna 28th, and Elevance 50th in terms of corporations worldwide.
Tom,
None of these companies need another penny from Connecticut ratepayers. They need much stronger oversight to make sure the vertically integrated corporate behemoths that are.
We have to move on to the next speaker.
Thank you very much.
Thank you. Next up is Kathy Flaherty.
Good afternoon. I want to thank the Connecticut Insurance Department for the opportunity to submit this testimony. As you consider the proposed rate hikes by several insurance companies, I join with those people urging you to reject those proposed increases. I really want to thank Commissioner Mays for his statement at the beginning of this hearing, recognizing that healthcare should be a right, not simply a privilege for people who can afford it. I submitted written testimony, so I'll keep this testimony very short. I am not only a healthcare consumer, I am also the executive director of Connecticut Legal Rights Project, and we are one of the state's small nonprofits that has gotten hit year after year after year with rate increases for insurance plans that we want to offer to our employees, even as the out-of-pocket costs for our employees have gone up. I personally am one of only 4 people at my office for health because our employees to get or have the option to get health care elsewhere does because our plan, frankly, is not great. It's a high deductible health plan. And what I'm finding, and the one question I have for these insurance companies, as someone who's living with long COVID, who is having doctors recommend treatment that my insurance company will not cover, I would really love to know from the insurance companies who are here today, what impact has long COVID, not just people being hospitalized for COVID during the acute stage of the illness, but people who have these long-term effects. What, if anything, has that done to your companies? And if you're denying people's care, how can you also at the same time claim that your cost for providing care has gone up? The cost increases are unsustainable for both employers and employees. That is why I have testified in favor of a public option every time a proposal has been presented. And I hope at some point that we will see all the people, all the stakeholders at the table in a joint effort to get these costs under control. Thank you.
Thank you very much.
Before we move along, Jen, would either of the insurance companies or both like to respond to the question on long COVID that was just asked?
Yeah, I would start by saying I think it's probably early to have a really good handle on what the actual impact of long COVID is going to be to costs. So I think we, as well as the clinical community, are still trying to figure that out. I certainly can't speak to the specific issue that was just raised in terms of a claim denial. But I think we're all, in terms of the question on what is the bigger picture impact, I think it's probably too early for us to comment on that in a quantifiable way.
I would second those types of comments, right? I don't have the specifics around the assertions that were made around the claim denials. And I think the whole world is still studying the impacts as it relates to long COVID.
Thank you. Next up is Jonathan Gonzalez. Okay, we're going to move on. Liz DuPont Deal.
Hi, is it on? Okay, thank you. Good afternoon. My name is Liz DuPont Deal. I am the Associate Director of the Connecticut Citizen Action Group. I'm speaking today on behalf of our thousands of member families, and I thank the Commissioner and the Department for having this hearing and for the anticipated other opportunity for the public to comment. I won't repeat on a lot of what's been said. CCAG, as has been stated, has undertaken a series of reports highlighting the profits and stock buybacks and other indicators, particularly focusing on the 5 companies that sent Governor Lamont the letter about the public option. If the public is interested in reading those reports, they're all available both on our Facebook page and also at ccag.net. We haven't talked today about lobbying expenses, which are further detailed in our initial report. So I'll just say, I will reinforce, for instance, some of the Cigna data that we collected showed profits of $5.36 billion in 2021. Stock buybacks, as has been stated, of $7.416 billion, which enrich company insiders really and do nothing else, with more stock buybacks planned and discussed publicly by Cigna. In addition to CEO David Cordani's $91 million compensation in 2021. It is indeed hard to justify that they are not giving us money back, given some of these numbers, even if they are national and not simply Connecticut. I would also ask for consideration at some point on the role of PBMs also. I haven't heard that discussed in great detail today, but pharmacy benefit managers are embedded into some of the requests that we're hearing, and the wrong incentives built into such a system are definitely worthy of scrutiny by this department and by lawmakers as we move forward. I'll just, I'll conclude and I'll welcome any questions, but I thank you for the opportunity to testify.
Thank you very much. Next up we have is James Williams.
Thank you, Council. My name is James Williams. I'm with the RTC of West Haven. I'm here to oppose the 20% increase on health insurance rates. My reasons are as follow. If the council allows the increase, it will hurt the working middle and lower class, which cannot qualify for state health insurance, Husky A, B, C, and D. Because of the already rising cost of living, people in these groups can be forced to drop their health insurance plans and run the risk of not being treated for pre-existing and future preventable diseases and health problems, which can contribute to a rise in deaths in the state of Connecticut. For health reasons, and if the deceased is the head of household, that family could be put into a bad financial state, and the family would have to apply for social programs that they would not have to have applied for before the death. Another point is, because hospitals are not allowed to turn people away for treatment by law, they're going to have a high number of uninsured residents that they're going to have to serve and run the risk of not getting paid, which will put hospitals in a bad financial state. Even people who are insured by private insurers, it's hard to get the insurance companies to pay the claim per customer and provider complaints. It will be a domino effect of bad circumstances that will follow if this proposal passes. As a Connecticut resident, I put my faith in my council leaders to make the right decisions to help sustain a certain level of quality of life for their residents. Healthcare is the difference between life and death for a large number of residents. We do not put profit before people in Connecticut. Thank you.
Thank you very much. Next up is Jill Zorn.
Thank you, Commissioner. My name is Jill Zorn, and I'm Senior Policy Officer at Universal Healthcare Foundation of Connecticut. I offer my comments on behalf of the foundation, as well as the 250 individuals who signed our petition demanding the CID say enough to out-of-control rate hikes. We urge the department to reject these double-digit rate requests, as they will force too many people and small businesses to go without health coverage. These rates are outrageous and unaffordable. They are far higher than the inflation rate and well above wage growth. We believe that CIG must take consumer affordability into account during the rate review process. With regard to the individual market, Universal was an initial funder of the Connecticut Healthcare Affordability Index. The index set a healthcare spending target. Residents should not spend more than 7 to 11% of their income in order to have affordable healthcare. The index shows that even with enhanced subsidies from the federal government, 42% of families purchasing coverage on the exchange have unaffordable health care. And families with above average healthcare needs face even greater affordability burdens due to high out-of-pocket costs. Meanwhile, we have even greater concerns about the small group market, which appears to be in a death spiral. Employers are being priced out of the market. Many are being forced to choose between an unwise financial risk with a self-funded plan or simply walking away. Even the organization I work for, Universal Healthcare Foundation of Connecticut, is facing tough decisions about how much longer we can offer this crucial benefit to our employees. Competition is shrinking in the small group market with the departure of Harvard Pilgrim. Most of the remaining insurers don't seem to be interested in competing on price. Instead, it appears they lack the clout or perhaps even the incentive to negotiate lower prices with a consolidated hospital industry and wealthy pharmaceutical corporations. By the way, Universal strongly supports regulatory efforts to address price gouging by these other two powerful industries. But we also support another solution to less competition and lack of negotiating power in the insurance industry, a public option. Research conducted by RAND Corporation shows that a public option based on the state employee health plan would show significant savings to small businesses, nonprofits, and Taft-Hartley funds. Yet insurers choose to spend our hard-earned premium dollars on anti-public option ad campaigns, even when there are no legislative proposals currently on the table. And they continue to earn huge profits, award highway robbery CEO salaries, and spend millions on stock buybacks, all while seeking to fund their financial gains with these out-of-control rate increases. Something is very wrong with this picture. We urge the Connecticut Insurance Department's actuaries to take out their scalpels and cut these shameful rate requests down to size. Thank you.
Thank you very much. Next up is Christy Talmadge. Okay, moving on. Brianne Chandler.
Commissioner Mays and members of the esteemed Connecticut Insurance Commission, I am Dr. Brianne Chandler, a general dentist. I own 2 private practices. I've served 8 years in the Connecticut Army National Guard, and I run a free clinic for homeless residents at the South Park Inn in Hartford. Today, I am here representing my profession and the Connecticut State Dental Association as the Chair on Governmental Affairs. We represent approximately 88% of Connecticut's dentists. I am here to advocate for patients who continue to pay insurance premium increases for the same amount of coverage and the same maximum benefit year after year after year. As an example, if a patient has a $1,000 maximum benefit, that maximum has not increased for at least 2 decades, despite yearly premium increases. Recently, as premiums have gone up, reimbursements have gone down. This is not what I want for my patient families, many of whom continue to struggle from the effects of COVID. It needs to be a priority to provide effective dental insurance so that families do not need to shoulder increased out-of-pocket expenses. There is no accountability for dental insurers. They are not held to the same standard as medical insurers. Patients have a record number of untreated infections. I'm seeing more swollen eyes and faces than ever before from untreated dental cavities and problems. Patients are forced to delay treatment, of these dental infections, and that could lead to severe medical complications as they run out of dental benefits for each year, or services needed get denied by their specific carriers. I offer two solutions. The first one, medical loss ratio. It sets a minimum percentage of patient premiums collected that must be spent on care, holding dental insurers accountable, just like their counterparts, the medical insurers are. It was mentioned earlier today that the medical loss ratio for Cigna is 85%. Dental insurers should be held to at least the same standard. Second solution, joint contract negotiations. 95% of dental practices in Connecticut are small businesses. Joint contract negotiations would allow dentists and dental providers, someone like me and my colleagues, a chance to negotiate at a different level with the large insurers. Thank you, Commissioner Mays, for holding this forum. Thank you to Attorney General Tong and Mr. Doolittle for highlighting the negative impact these rate increases would have on my patients and all dental patients across our great state. Thank you.
Thank you very much. Next up is Paul Kriske from Branford. If I'm pronouncing your name correctly, I had trouble with your handwriting. Kriske, thank you.
Wow, you guys signed up for the bonus plan today, didn't you? My name is Paul Kriske. I'm running for District 12 State Senate, but I'm here on behalf of my business as a small business owner. I guess the question really is, because you've pretty much heard to nauseam how people feel, and I will congratulate you because I really do think that you broke the code on how to bring bipartisanship to the state, because everyone's on the same page today. What's enough? How much is enough? You really have to ask yourself this, because this is kitchen table talk. I've heard a lot spoken about today. But the fact of the matter is that people are sitting home at their kitchen tables trying to figure this out, and they're small business owners. And there's a great big difference between how we calculate our profits as a small business owner versus how we're going to calculate greater profits. You have to understand that people's mental capacity, their ability to understand what you're talking about, is unfathomable. We've beaten up on the CEO pretty good today about his $91 million. How do you justify it? How do you speak about it? What is enough? What family costs that he has, or what kind of life-saving moments does he have that he is actually justified in making? I'm a capitalist by heart. I believe in everyone making money, but there is a point of desensitizing the public to the realities that you're offering. So to sit here and explain, and we've heard the terms about, I think that we've mentioned about like trying to predict numbers. The average business person is trying to predict if they're going to make it through next year. And I don't just put this at your feet. I do put it at the state's feet also, because we die a death of 1,000 cuts on taxes, and people relate taxes. When you talk about taxes, you see it in your paycheck, but they forget about the tax on everyday clothing and everything that we have. We've gotten to a point that we're getting to a point of no return. The commissioner made a very good point. It's a right to have medical, not a privilege. I was very proud of the fact that during COVID, I did not have to lay off a single employee. And believe me, I was not having fun, because I missed the first round of COVID. And I was talking to my bank, and I had to hear about, well, you know, it's not your turn yet, and I took a picture of the news, and I'm saying to him, I'm watching big corporations get the money before small business does. You have to understand something, that the jobs you chose, and unfortunately you were sent here today, you represent something that is supposed to be for the good of the people. But now you've put yourself into a position that you represent what everybody hates. We've taken capitalism in its purest form and we've turned it into just something bad. Because the fact of the matter is, if my calculations are right, you are actually showing profits in your first quarter greater than last year. That doesn't make sense. It's about common sense. It's about the people being able to afford things. They are dying a death of 1,000 cuts. And if we can't figure out how to do this properly, I would say this. I heard the bell go off. He's going to make me leave shortly, if not immediately. Leaders eat last. It is a bad optic at the very best to have CEOs making hundreds of millions of dollars or tens of millions of dollars while we're going to ask not for a modest increase, but a 20% plus increase.
Thank you very much.
Thank you very much for your time. I appreciate it. Have a great day.
Next up is Wes Skotsky, if I'm pronouncing that correctly. Skorsky? Mr. Skorsky, please go ahead.
Thank you. Good morning. Well, I wrote that this morning. Good afternoon. Thank you for your time. My name is Wes Skorsky. I'm from Marlborough, Connecticut. I'm here first as a small business owner. I own a small trucking company, and this year we've seen diesel costs go up by 50% or more. Costs for equipment have also gone up dramatically. A tractor that used to cost me $150,000 2 years ago now costs over $200,000 to purchase. Across the country and in my company, average age of commercial drivers is almost 50 years old. That means that they're in the higher rate bands. With a 20% increase in premiums, some of my drivers will have an increase of over $3,600 per year in their premiums. They'll have to switch to a high deductible plan, making healthcare inaccessible, as one of the other speakers mentioned before. If the deductible is too high, you don't utilize your insurance. A rate increase of this magnitude will further increase the cost of doing business in Connecticut and be a deterrent for new businesses starting or moving to Connecticut, and will especially hurt the middle class in their pocketbooks, and more importantly, their health. My other role, besides running the trucking company, is chairman of the Board of Education in Marlborough. In Marlborough, our bargaining units are part of our health insurance consortium. This year, our rates, or for the upcoming 22-23 fiscal year, our rates actually went down by 6%. Let me repeat, they went down by 6%, and that's without a change in benefits provided to the bargaining units. The rate increase was partly due to a decrease in utilization during the peak of the pandemic. We've heard the representatives of the insurance companies talk about the decrease in utilization, but yet they're still asking for a 20% increase. I ask that the commission not approve this rate increase and further review the proposal. Thank you, everyone, for your time.
Thank you very much. Next up is Karen Siegel.
Good afternoon, everyone. I'm Karen Siegel, and I'm the Director of Policy for Health Equity Solutions. I submitted comments in writing. I just wanted to highlight a couple of key points, and thank you for the opportunity to do so. What I really wanted to focus on is that there's solid evidence that rates don't have to be this high for plans to remain solvent and insurance companies profitable. And I say this because rates in Connecticut are higher than 42 other states, because recent transparency efforts have validated the assertion that there's no correlation between the cost of hospital care and the bills paid by insurers or by patients. And finally, because other states are doing far more to control costs, sometimes with cooperation from insurers. So just for example, health insurance companies in Colorado have recently agreed to reduce premiums by 15% over the next 3 years, while Connecticut insurers are asking for a rate increase of an average of 20% in 1 year. It's an unfortunate and unintended consequence of medical loss ratio requirements that insurers profit when hospital and provider rates increase, right? There's no incentive for insurers to try to keep costs down. And that's a particular concern in a state like ours, which has seen dramatic provider consolidation, which also is known to lead to cost increases. One of the tools that Colorado is using to safeguard the required decreases in premiums is to hold hearings that assess the impact of hospital and provider pricing on rate setting. And they use Medicare rates as a benchmark to ensure fairness to providers and that this doesn't have an impact on network adequacy. And they're benchmarking at 165% of Medicare rates, which I think is a really useful model in kind of taking into account the needs of all stakeholders. Rhode Island also embeds cost containment in its rate review process and limits price increases for hospitals. And Connecticut's cost growth benchmark offers an opportunity to pursue a similar approach here because it provides the infrastructure necessary to do that work. So I would just urge I think it's excellent that there are all three branches of government have been represented here today, and I think we can work together to implement some solutions to these problems. I think the problems themselves have been, there's quite a lot of consensus around them, and I just wanted to highlight that there are these opportunities to address this issue. So thank you very much for your time and the ability to comment. I appreciate it.
Thank you very much. Next up is Mike Smith.
Good afternoon, Commissioner, and everyone that's here in person and virtually. I want to add my voice to the outrage over the proposed increases in health insurance rates and encourage more opportunities for the public and policymakers to ask the tough questions. 14 years ago, I was diagnosed with cancer, but I'm one of the lucky ones. When I was diagnosed, I was 21 years old enough to be an adult, but young enough to be on my parents' health insurance. Thanks in part because of the policy decisions made by the folks in this building. I was lucky because my cancer presented in my neck rather than in my abdomen. It was the size of a golf ball, but at the time it was finally diagnosed. I was otherwise asymptomatic. I was lucky because my boss that summer was one of those guys that wouldn't let up about making sure that I got that lump checked out. I was lucky because it was only stage 2A when I was diagnosed, and that I only needed 6 rounds of inpatient hospitalization, chemotherapy, about 30 odd days in the hospital, a dozen blood transfusions, and more of those death waivers than I can count. You know, those waivers that say you need to have this medicine to stay alive for years, but there's a chance you might die in minutes. I was lucky that my mom worked a job that provided good quality health insurance. Otherwise, I'd be still crawling out of the nearly $1 million of medical care needed to keep me alive. But we shouldn't leave the health and the financial fate of our family, friends, and neighbors to luck. Like so many other things in the last few years, health insurance and prices have gone up. But unlike a pickup truck or an SUV, you can't downsize your health care and save on gas. When costs for health insurance get too expensive, you go without. We can, we should, and we must do better. Because even when you have insurance, it's still expensive. Just last week, I was talking to a friend, 32-year-old woman, business owner. She was talking about how she went for routine cancer screening and still had, even with a gold medal plan, still had to pay thousands of dollars in out-of-pocket costs. We can, we should, and we must do better for the citizens of our community. It turns my stomach to hear the stories from parents where they're dodging collections calls because their insurance provider won't provide the chemotherapy needed to keep their child alive. That's why I'm here today, to encourage you to ask the tough questions and not be satisfied with only reducing health insurance premiums by a few points. We must do better by our family, friends, and neighbors. I don't know the solution. I'm certainly not an actuary, but I have faith in the intelligence and the compassion of the folks in this room and in our state, that if we ask the hard questions, we can fix this system so that surviving a tough medical diagnosis, both physically and financially, isn't based purely on luck. Thank you.
Thank you very much. Next up is Jan Kritzman.
Good afternoon, Commissioner Mays and attendees here. My name is Jan Kritzman. I live in Newington. I'm a 10-year breast cancer survivor. I'm the one that championed Public Act 22-90, which became law in Connecticut this past session. Public 22-90 makes Connecticut the first and only state in the nation to mandate insurance coverage for the earliest possible early detection of both breast and ovarian cancer with no financial barriers for an insured to receive both screening and diagnostic testing for the earliest possible early detection of these two dreaded and costly diseases. No deductibles to have to meet, no copays, no coinsurance, no cost sharing. And the bill contains, the law, excuse me, I've been calling it a bill for 5 years, and after 5 years, it's finally a law. And much, much more. Read it, you'll love it. The wording of this landmark law specifies not just women, but also men and transgenders, anyone with breasts and or anyone with ovaries. It uses the word insureds. Connecticut bears the dubious distinction of having the second highest rate per capita of breast cancer in the nation. Approximately 3,600 women and 250 men annually diagnosed in Connecticut with breast cancer. Approximately 300 plus cases and growing of ovarian cancer in Connecticut. You don't know how devastating the words are, you have breast cancer or you have ovarian cancer, until you, God forbid, hear them yourself. If you want serious medical debt, these diagnoses will certainly load you up on it. In the several years that I've been championing this bill, which finally became law, I realized that 22-90 would save insurance companies enormous money. I'm saving you money. I'm doing you a favor with 2290. You're welcome. Example, early diagnosis of breast cancer involves a lumpectomy and radiation, approximately $30,000 maybe to $50,000, depending on where you live in Connecticut. And those figures are easy to substantiate. Late stage diagnosis, stage 4, for example, involves mastectomy, reconstruction, chemotherapy, radiation, and one expensive clinical trial after another. Stage 4 cost maybe $1 million. Stage 4 breast cancer and ovarian cancer is a terminal diagnosis. There's no cure. Life expectancy is maybe 3 to 5 years if the patient is a single parent of 2, 3, 4 children. If the patient dies and the children go into foster care, tremendous cost to the state of Connecticut. I can't state enough the value of Public Act 22-90, both financially, physically, and psychologically. Again, I will remind you that this law does you a big favor. I don't wear pink because I like pink. I hate pink. It's not my color. But pink has major significance. Not just, I'll be done in a minute. Not just awareness of breast cancer with the pink ribbons. We're all aware of breast cancer, but it hits home. And that's where you insurance companies come in, about the importance of not just early detection, but the earliest possible early detection, which is the only tool we have to provide long-term prognosis and life and cost savings to the patients and to your industry. Of special note, 2 of my amazing dedicated legislators which had to leave, both co-chairs of the insurance committee, Kerry Wood and Matt Lesser, and others who are here today were my torch bearers. Again, all breast matters, give a damn, get a mammogram.
Thank you very much. That concludes the public portion of our meeting today. Commissioner?
Thank you, Jim. And are we sure there is nobody else in this room who wishes to speak? Or is there anyone who's raised their hand online who wishes to speak? Jim, Alex, anyone?
I don't believe so. I think we're finished.
Thank you. Well, thank you all for coming today. Thank you to those who testified. I do want to just take a point of personal privilege here to address a couple of items that were raised. One had to do with, let me call it the ecosystem that we're looking at. I think Liz mentioned PBM, somebody else mentioned cost growth benchmarks. Those are all, if you come in October, when the Office of Health Advocate holds a hearing with us, you will see what we are trying to do is pull everybody in. Over the course of the past year, we've had discussions that led, among other things, to the cost growth benchmark. We need to address the entire system, not just any isolated part of it, in order to make a difference. And, we can't tinker around the edges. We need to make changes, and that's what we're planning on doing. That's what we hope to do. So I just want you to know this is not an end today. This is in many ways a beginning. And the other item, I know Kathy had mentioned that she had a claim that was not covered, and James had mentioned that there was a claim that wasn't paid. I just want to make sure the insurance department has a consumer affairs division. It's 860-297-3800. There's also an 800 number, 800-203-3447, or you can just send an email to insurance@ct.gov. That will help you out with all our insured plans. And for the other plans, the Office of Healthcare Advocate does a great job of reaching out and trying to help. You can reach that office at 1-866-466-4446 or healthcare.advocate@ct.gov. Both the department and the healthcare advocate if we can help you, we will. This is a good part of our job, being able to help people. And if you've had a problem with your coverage, please reach out. Now, since we have nobody else, I think, who's planning to testify, we will conclude this meeting. Thank you all for being here all day. I know we've all got busy schedules, and I appreciate the input, appreciate the insight, appreciate the comments. Please feel free to check our website where you will see